Hi everyone, a very good evening to each one of you. Myself, Dr. Vaibhav Jain, and today we will be discussing about the medicine. So before starting it off, give me a quick confirmation whether I'm clearly visible and audible so that we can proceed with the session. All right, wonderful, Ritu. Good evening, good evening. All right. So in today's session, what we are going to do, we are going to learn about the important topics in medicine that can be asked in your examination. So I have get all the important questions that can be asked in your examination, right? We will be discussing about that, right? So we will be starting it off with the question number one. The question number one we are having in front of us. Try to answer. You guys have to be interactive with me. We will be discussing all the important concepts of CNS today. So in today's section, we are going to discuss about the CNS. We are going to discuss about the hepato. We are going to discuss about the GIT questions, right? And just a moment. All right, so these things we are going to discuss today, right? So let's begin. Try to answer. What do you think, what is going to be the answer in this particular case? A 26-year-old female is presented to the OPD with the symptoms of, what are the symptoms she is having? She is having headache. Along with the headache, she is having nausea. Along with that, she is also having the vomiting. The pain is unilateral. The pain is unilateral, and that will aggravate with sound, and photophobia is there. The pain is aggravating with sound. What do we call it? The pain is aggravating with sound. We call it phonophobia. Phonophobia is there, right? And another thing that is mentioned over here is the photophobia. Okay, what is the most likely diagnosis in this particular case? Very good, guys. I hope all of you are getting it correct, right? So everyone is answering D. That is going to be your migraine. Let's try to understand what is migraine. Can anyone tell me, migraine is more common in males or females? Remember, migraine is most common in females as compared to males. What are the symptoms you will be having? You will be having phonophobia. Along with that, you can have photophobia. Photophobia means you will be having pain because of light. That pain will be aggravated because of light, right? What is the most common type of headache? What is the most common type of headache? If I ask you, what is the most common type of headache? Most common type of headache is not migraine. It is going to be your tension headache, guys. Tension headache followed by migraine. Followed by migraine, right? This is going to be the most common type of headache, right? So first thing, let's try to discuss what are the important things you need to know about migraine. So migraine, what is the criteria that we guys are going to study about migraine? The criteria we follow, this criteria is known as Pound's criteria. What is the name of the criteria? Pound's criteria. Very good. Pound's criteria. What are the things we are having in the Pound's criteria? Remember, they can give you all except question. All except question. So we are having what? It is going to be pulsatile in nature. It is going to be a 1-day illness. It is going to be 1-day illness. It is going to be U for unilateral. Unilateral throbbing headache. It can be aggravated due to multiple things. खाना नहीं खाया morning में, pain हो सकता है, right? You are skipping your breakfast, that can even lead to pain, right? It can cause nausea, and for nausea, and D for disability. Disability, right? Patient अपना काम नहीं कर पाएगा. Patient will be sleeping in a dark room without sounds, right? That is going to be the Pound criteria. What is the cause? What is the cause? What is the cause for this particular thing? We assume that cause is CGRP. CGRP is calcitonin gene related peptides. CGRP, right? And what is going to be the treatment, guys? For mild cases, try to answer. Treatment for mild cases. For mild cases, we are going to give what? First of all, we will try our NSAIDs, non-steroidal anti-inflammatory drugs. These are drugs like paracetamol, aspirin, or sometimes we are also using naproxone. Along with this particular thing, we are also using metoclopramide. Sometimes we are using metoclopramide if the patient is presenting with the vomiting, right? In the moderate to severe cases, question has been asked on this, moderate to severe cases, the drug of choice will be triptan. The drug of choice will be triptans. Triptans are going to be your 5-HT1B 1D agonist. These are your triptans. These are your triptan. 5-HT, 1B, 1D agonist are going to be your triptans. But remember, don't give triptans in the cases of ischemic heart disease, because they can precipitate more coronary vessels problems, right? So in ischemic heart disease, we are going to use the drugs. These are going to be your CGRP receptor antagonist. CGRP receptor antagonist. Can anyone tell me the name of the CGRP receptor antagonist? Anyone? Very good. These are going to be your GPANTs group of drugs. These are going to be your arbogepant. I am integrating subjects as well. Okay, we are having arbogepant, we are having rimegepant. Yes, and for prophylaxis of migraine, we are using propranolol. Apart from propranolol, we can also use anticonvulsants, like we can use topiramate. We can also use drugs like flunarizine. Okay, so this is the pretty much that you need to remember about the first thing, that is going to be your migraine. Second thing, that we are having this particular image. What is this particular image is concerned with, guys? This is your giant cell arteritis. What is the presentation? How they are going to ask you question? They are going to give you, either they are going to give you this particular image, otherwise they are going to write in the question, they are going to give you temporal headache. Try to identify the keywords. Today I am going to teach you about meningitis, pneumonia, all these things. Pulmo also we are going to cover. So all these things I am going to give you the keywords. Those keywords, if you see in examination, you will directly reach out to your answer, right? So if they are going to give you temporal headache along with the jaw claudication, okay, in question if they write you elevated ESR, or fever may be present, fever may not be present, fever will be plus minus, right? This is going to be the presentation that you are going to see in the cases of giant cell arteritis. Remember, this is also more common in females as compared to males. This is also more common in females as compared to males, right? What is the artery that is involved? This is your previous year question 2023. What is the artery that is involved? Remember, here you will be having tender, palpable, superficial temporal artery. Very, very important. Superficial temporal artery. Artery is the most common involvement. Very, very important. Superficial temporal artery is the most common involvement in the cases of giant cell arteritis, right? When you are going to do the biopsy, what you are going to get? So on biopsy also we had a question long back in 2019. We had a question, right? You will be getting multinucleated giant cells. Multinucleated giant cells will be present. You will be getting pan-arteritis. You will be having granuloma. Okay, apart from that, you will also have fragmented, write down, fragmented internal elastic lamina. Very, very important, guys. Fragmented internal elastic lamina. These are going to be your biopsy finding in the cases of giant cell arteritis. How you are going to treat this particular situation? For the treatment, this you are going to give steroids. First line, you are going to give steroids. Along with that, you can also use aspirin. Okay. In one question in INI set, they have asked you can also use interleukin 6 inhibitors. Can anyone tell me what is this interleukin 6 inhibitors? Interleukin 6 inhibitor. What is that interleukin 6 inhibitor we are going to use in the cases of severe cases of giant cell arteritis? Interleukin 6 inhibitor. I'm waiting for your response. That is going to be your sarilumab. This is going to be sarilumab or tocilizumab. These are going to block the cytokine storm. We have also used these drugs in the cases of COVID-19 as well, right? Tocilizumab, very good, Anas. That is going to be your tocilizumab. Now, lastly, we are having tension type of headache. Tension type of headache. Tension type of headache will be a bend-like headache. You will be having episodic headache and chronic headache. Episodic and chronic headache will be present. And this is the most common, we have already seen, this is the most common type of headache that we are having, right? Here you will be having pain in a band-like manner, right? So here you will be having tight band-like headache. And what would you like to give for the treatment? This is going to be treated with the normal NSAIDs. Remember, this headache is not because of tension. There are multiple factors which are going to precipitate, right? Tension headache मतलब tension की वजह से नहीं है, right? So that is going to be your tension headache. Next, lastly, we are having the cluster headache. Cluster headache. So where do you find this particular patient? Will be a young patient presented to hospital. He will be having severe retroorbital pain. Okay, so in the question he will be writing you young patient history will be giving. Okay, here this particular patient will be having periodic headache, and this pain will be present in the retroorbital area. Okay, so here you will be having severe retroorbital pain will be there. Severe retroorbital pain will be there. So you can look here. Okay, in migraine you will be having pain which is going to be unilateral. Okay, in tension headache you will be having a band-like pain. In sinus you will be having multiple sinuses, paranasal sinuses, that would be having the pain like frontal sinusitis is going to cause what? Office headache. And this is going to be your cluster headache, which will be having retroorbital pain will be there, right? How you are going to treat this particular situation? In the acute cases, guys, you are going to give oxygen plus triptans. Oxygen plus triptans are the drugs you would like to give. Oxygen is the treatment here. Or for long-term cases, you would like to use long-term, we will be using calcium channel blockers like central one, that is going to be your verapamil. We can also use drugs like lithium, right? This office headache is because of frontal sinusitis. Here you will be having pain in the frontal region. That is going to be your office headache. One more headache they can ask you, all the headache I have compiled, right? One more headache they can ask you, that is going to give you in the case scenario, the worst headache of my life. Anyone try to tell me worst headache of my life, or thunderclap headache. If they write you thunderclap headache or worst headache of my life, क्या होगा बेटा ये? Worst headache or thunderclap is going to go in the favor of, very good Rituraj, that is going to be in the favor of subarachnoid hemorrhage, right? So we have already discussed about the headache. Now you know what is a giant cell arteritis, what is a tension headache, what is a cluster headache, what is migraine, and how they can ask you question based on SH, right? All the keywords are important. If the headache is there in the unilateral region, one side of the head is having the pain, that is going to be in the favor of going in the favor of migraine. In cluster headache, you will be having retroorbital pain. If the pain is in the band-like manner, that is going to be your tension headache. And lastly, giant cell arteritis will be having a headache on a particular part, and the classical appearance will be there, right? There will be some classical appearance that you need to remember, right? Now try to solve this second question that we are having. A 29-year-old male patient is presented to emergency. The patient is presented to emergency with the symptoms of, this patient is having what? High-grade fever. This patient is having what? High-grade fever and headache. On further examination, the sign that is shown in the image comes out positive. These are the two signs which are there, right? This one and this one, these are the two important signs we are having in the image. They are coming out to be positive, right? On lumbar puncture, the lumbar puncture was done, and on CSF analysis, it shows the turbid CSF. What is the CSF that we are having? Turbid CSF with glucose around 20 and raised proteins and lymphocytes around 150. So we are having raised proteins, we are having glucose around 20, we are having lymphocytes around 150 cubic mm, right? What can be the most appropriate diagnosis in this particular case? First of all, try to tell me what is your diagnosis here. What is your diagnosis? Everyone is answering tubercular, right? First of all, tell me what is this particular sign? What is this particular sign on the this is going to be your Kernig sign. Kernig sign. On the extension of knee, there will be pain. There will be pain, that is known as Kernig sign. And that second sign that we are having, this is going to be your Brudzinski sign. Both of them are going to be positive in the cases of meningitis. So what is going to be the things you will be suspecting in the cases of meningitis? Meningitis में क्या क्या मिलेगा बता? Meningitis में you will be having pain, you will be having fever, headache will be there, right? And nuchal rigidity will be there. Nuchal rigidity will be there, right? These are the sign. Pain in head, headache will be there. Headache will be there, fever will be there, nuchal rigidity will be there. Along with that, you can have projectile vomiting, you can have Kernig positive, you can have Brudzinski positive. All these things are going to go in the favor of meningitis. All these things are going to go in the favor of meningitis. Tell me, where do you get the lumbar puncture? Lumbar puncture कहाँ से करते हैं? What is the site for lumbar puncture? What is the site? What is the site for lumbar puncture, beta? From where we get the lumbar puncture, right? And what we are going to see, appearance कैसा आ रहा है? The appearance of the CSF, appearance of CSF is going to be turbid here. Turbid CSF we are getting, right? Very good. Yes, very good, Ritruas. That is going to be L3 and L4 is going to be the site from where we are going to do the lumbar puncture. ठीक है, अभी identify करते हैं. This is a very important question. Every time examiner is asking, they are fond of this particular type of question. Okay, we cannot make these questions wrong. ये simple questions हैं, इनको गलत नहीं करना है. Just try to understand कैसे solve करना है. Okay, so what we are having, they have given glucose is around 20. What is the normal glucose, beta? What is the normal glucose? Normal glucose is going to be around 50 to 80 milligram per deciliter, or you can also call it like 2/3 of the blood, whatever blood glucose we will be having, right? Second thing, if they talk about protein, what is the normal protein? That will be around 15 to 60 milligram per deciliter, right? If you know these things, what you will identify that this particular case, the glucose is around 20. That means glucose is what? Glucose is low. In this particular case, the glucose is low. Second thing, what about protein? There are raised protein is high. So let's try to understand how we will differentiate meningitis on the basis of appearance, or on the basis of CSF examination, right? So what is going to be the appearance? Let's talk about the bacterial one. You know what? Bacteria loves glucose. Bacteria loves glucose, right? So what bacteria will do? Bacteria will eat up all the glucose. If bacteria will eat up all the glucose, what will happen in bacterial meningitis? There will be very low glucose. There will be very low glucose. First thing you understand. Second thing, what happens with the protein? Bacterial meningitis, you will be having very high protein, beta. Very high protein will be there, right? What is going to be the appearance of bacterial meningitis? Bacteria क्या करेगा? उसको गंदा कर देगा. So you will be having yellow turbid appearance. You will be having yellow turbid मतलब गंदा appearance होगा. Okay, apart from this, we are going to have certain cells, right? What are the cells we are going to have over here? मैंने पढ़ाया था, I have taught you in physiology as well. What is going to happen whenever there is a bacterial infection? It is going to increase what? You will be having increase in the levels of neutrophils, right? So you will be having neutrophilia. Okay, and sometimes in the question they will also write PMN. Okay, PMN भी लिख सकते हैं. Neutrophilia will be there, so you will be having very high neutrophils will be there, right? Lastly, about the pressure will be high. Pressure means when you are going to do the lumbar puncture, उसमें से कैसा flow आ रहा है, that is known as opening pressure or pressure, right? So the pressure will be high. So first thing we have seen in the question, we are talking about lymphocytes, right? In this, bacterial cannot be the answer because sir, bacteria is concerned with the neutrophil. Second, let's talk about the viral one. Let's talk about the viral one. What is going to happen? Virus is going to produce serous fluid. Whenever you are having viral infection, running nose, anything, you will be having clear viscous fluid that is going to come out, right? It will be clear. Apart from that, what happens with the proteins? That it is not going to do anything with the proteins, so proteins will be normal. What happens with the glucose? Glucose will also be normal. Virus is not going to eat up the glucose, it is going to be normal. But what happens when you are going to have a viral infection? You will be having increase in the levels of beta lymphocytosis will be there. Lymphocytes will be increased. Lymphocytes will be increased, right? Apart from that, what about pressure? Pressure will be high here also, right? So that is going to be the viral case. Lymphocytosis is there, but sir, proteins and glucose are normal, right? So is it going to be our answer? No, this cannot be our answer. Lastly, we are having tubercular. Tubercular, you will be having again turbid CSF. Apart from that, you will also have a specific appearance. Earlier they used to give this cobweb coagulum in the question, but right now everybody knows about this cobweb coagulum, so the examiner is avoiding this particular thing, right? This is a characteristic feature you will be getting in the cases of TB. In the cases of tubercular meningitis, you will be having cobweb coagulum, right? What about proteins? Sir, proteins will be very high. Proteins will be very high, right? What about the glucose? Sir, glucose will be low because it is also a bacterial infection, right? What about the cell? It is a chronic infection. Remember, TB is a chronic infection, and in chronic infection, what will happen? You will be having increase in the levels of lymphocytes beta. So you will be having lymphocytes will be increased, and you will also have what? High opening pressure will be there, right? So this is going to be the picture. This is going to be the picture for tubercular meningitis. Now I hope you will be able to understand. Now if you get a question on meningitis, any type of question, they will be writing what words, what are the important keywords you have to look for? Lumbar puncture, CSF. If they are going to give you CSF, lumbar puncture, Karnik, Brudzinski, nuchal rigidity, headache, fever, projectile vomiting, all these are going to be the signs of meningitis. And in this particular thing, you will have to understand the concept. Viral agar pucha hai, viral, that is going to increase your lymphocytes. Apart from that, tubercular is also going to concern with the lymphocytes. That is also going to concern with the lymphocytes. About these two important things I am going to teach you. Okay, let's try to understand about the normal causes of meningitis. What are the normal bacterial causes of meningitis? Okay, try to answer. Be interactive. What is the most common cause of bacterial meningitis in adults? What is the most common cause of bacterial meningitis in adults? Okay, that is going to be your pneumococcus beta. I have taught you in microbiology section also, pneumococcus or streptococcus pneumonia, or that is going to be the most important organism that is going to cause most common cause of meningitis, and it is also the most common cause for what? Pneumonia. It is also the most common cause for pneumonia, right? In elderly patient, they have given you in the last exam, they have given you a question, and in that particular question they have given you the image of meningitis, and in that meningitis they have given the patient was elderly. So whenever they want to ask you about meningitis and the patient is an elderly patient, what you need to think? You need to think in the terms of listeria. I have taught you in micro, Lisa antivala, right? So that is going to be the listeria. That is going to be the listeria, right? Most common cause of meningitis in the cases of neonates, that I think all of you would be knowing, that is going to be your group B streptococci or agalacti. We can also call it Streptococcus agalacti. That is the worldwide. If they ask you in India, that is most common is going to be your E. coli. You can remember this sequence, you will be able to answer the question, right? If they want to ask you question based on the meningococcal meningitis, what they are going to write? They are going to write headache will be there, fever will be there, nuchal rigidity will be there, plus rash will be there. Very important thing, you have to think in the terms of, if they have given you the rash, you have to think in the terms of meningococcal meningitis. Okay, after this we are having, after neurosurgical procedure, that is going to be your staph, the staph aureus. Any bone infection, neurosurgical procedure, you have to think in this in the sense of staph aureus. HIV positive patient with meningitis, that is going to be your Cryptococcus neoformis, right? Cryptococcus neoformis. We are using the negative stain, India ink staining, right? Nigrosin. That is what is Cryptococcus neoformis. Cryptococcus neoformis. What is the most characteristic finding in TB meningitis? Just now we have seen that is going to be better cobweb coagulum. Cobweb coagulum, right? This molarate meningitis is because of herpes simplex virus 2, HSV2. And remember, this HSV can cause encephalitis also. This HSV can cause encephalitis also. And in this particular encephalitis, what is going to happen? You will be having focal neurological deficit will be there. You can have seizures. Patient can have seizures. Plus, this is going to involve the temporal lobe. Guys, this is a very important infection, like temporal lobe involvement will be there. ये पूरे इंसान की लाइफ खराब कर देता है. इफ समवन इज हैविंग लाइक HSV encephalitis, what will happen? It will completely damage the area of the brain. Basal ganglia डैमेज कर देगा. मेमोरी पूरी चली जाएगी, पुरानी मेमोरी. ही विल नॉट बी एबल टू बी द सेम पर्सन, राइट? मोस्टली ज़्यादातर लोगों में क्या होता है? दे आर फॉरगोटिंग एवरीथिंग वॉट एवर दे वर बिफोर द इन्फेक्शन. दे आर नॉट द सेम पर्सन, राइट? They can have multiple things, right? So this is your HSV encephalitis. It is going to cause the temporal lobe involvement will be there, right? So this is about the meningitis. Now I hope you will be able to solve this type of question. Meningitis question definitely will be coming in your examination. I am going to solve only those questions along with you that are repeatedly asked 5 to 6 times. Okay, so वही सारे topics हम लोग करेंगे today, right? So just be with me. Okay, next question we are having. A 37-year-old male patient is presented to the emergency after a road traffic accident. The patient had a very severe headache. In fact, he called this headache the worst headache of his life. Worst headache of his life, right? Along with that, patient is also having nuchal rigidity. The NCCT head is shown below. What is the most likely diagnosis? What is the most likely diagnosis, beta? Is it a subarachnoid hemorrhage, subdural hemorrhage, extradural hemorrhage? What is it? So what is the history that is given? You always need to think about that. After a road traffic accident मतलब trauma. Road traffic accident मतलब it is a case of accident. मतलब यहाँ पर क्या हुआ है बेटा? यहाँ पर एक trauma हुआ है. And trauma, remember, is the most common cause for subarachnoid. Very good. Trauma is most common case for subarachnoid hemorrhage. Okay, and what is going to rupture in this particular case? In subarachnoid hemorrhage, what is going to rupture? Where is going to be the lesion? You will be having rupture of Berry aneurysm. You will be having rupture of Berry's aneurysm, right? How you are going to proceed for the case? What is going to be the investigation of choice? What is going to be the investigation of choice in any road traffic accident case? What you would like to do? Is it going to be a, this is also exam question. They are giving you options like gadolinium and enhanced MRI. Are you going to do CT scan, or are you going to do contrast CT? What you are going to do in this particular case? Yes, you are going to do NCCT. Very good, Mohammed. You are going to do what? NCCT of the head. NCCT is the first line investigation, right? After that, on lumbar puncture, what you are going to find? If you do not have NCCT and you are doing the lumbar puncture, you are going to find xanthochromics. First, you will not find it on the first cases. पहले क्या मिलेगा? Blood mixed CSF मिलेगा. Then after sometimes what will happen? You will be having xanthochromic CSF. Xanthochromic मतलब CSF के साथ में क्या mix हो गया? Blood mix हो गया. That is what you will be finding in the lumbar puncture. And what is the gold standard test? This was your previous year question. Gold standard क्या करोगे? You will be doing 4 vessel angiography. 4 vessel, you can remember 4 vessel conventional angiography. Conventional angiography is the gold standard. Whenever you see a picture of CT, what you will be looking at? CT में सबसे पहले क्या देखोगे? Outermost part will be white. ये बाहर वाला cortex वाला हिस्सा कैसा दिखेगा? It will be looking white. It will be normally looking white on a CT, right? Here you will be having this dense black color will be there. और यहाँ पर क्या होगा? It should be having what? It should be having the CSF. Now what will happen? Here you will be having mixing of CSF with the blood. Here you will be having mixing of CSF with the blood in the Sylvian fissure, right? Basal cisterns or Sylvian fissure में that is going to be present with the subarachnoid hemorrhage. Now let's try to summarize all the different types of intracranial hemorrhages we are having. Let's try to summarize. Okay. So first let's talk about the treatment part of the SAH, subarachnoid hemorrhage. For the treatment, you are going to give which drug? You are going to use nimodipine. First you will be giving nimodipine, and then you will try to recover the things, right? Then you will try to repair, followed by repair. Repair should be done within 24 hours. Why? Because it can rupture again. So you need to do the repair. The surgery that we are going to do is going to be your endovascular coiling with aneurysmal clips. Endovascular coiling, we are going to do endovascular coiling with the aneurysmal clips, right? So this is going to be the treatment for subarachnoid hemorrhage. Yes, we can do clipping, endovascular clipping, right? Now next we are having is intracranial hemorrhages. We are having all the layers. What are the different layers we are having? We are having outermost layer, सबसे दूर है, that is your dura mater. Then we are having arachnoid, then we are having pia mater, right? If the accumulation of blood is above the dura, देखो इन दोनों के बीच में अच्छा खासा स्पेस होता है, so we can have accumulation of fluid here, that is known as epidural hematoma, EDH. We call it epidural hematoma, EDH. Then we can have subdural, below this particular thing we can have accumulation of fluid, that is known as subdural hematoma. Then we can have below the arachnoid accumulation, that is known as subarachnoid hemorrhage. And then we can have इन दोनों के बीच में space नहीं होता, then we can have problem with the parenchyma. Then we can have direct problem with the parenchyma, that is going to be your intracerebral hemorrhage, that is going to be your ICH, right? So we can have epidural. Remember, what are the signs you will be finding? In epidural you will be having this type of convexity, right? In epidural you will be having this particular thing. This is known as what? कौन सा sign बोलते हैं? We call it what? Sometimes we call it what? This is also known as which sign? Try to answer. Okay, here in second case we are having this type of opacity here, right? This is your banana. Okay, this is going to be your lemon sign, we call it banana sign in the cases of subdural hematoma. Then we can have subarachnoid. Just now we have studied about SAH, right? Here you will be having blood in the Sylvian fissure and basal cisterns, and this is going to be your intracranial hemorrhage. This is going to be your ICH. This is going to be your intracerebral hemorrhage, ICH, right? This is going to be your ICH. So let's try to differentiate. How we are going to differentiate between them? Let's make a table around it, right? So first thing, in the cases of EDH, you will be having this type of thing, right? On the NCCT head, that is going to be your lemon sign. What is the artery? What is the vessel that is going to get injured in the cases of EDH? Quick, fast revision we are doing, guys. This is going to be your rupturing middle meningeal artery. Middle meningeal artery. Here you will be having rupture of the middle meningeal artery. How it is going to appear on the NCCT? This is going to show you lemon sign, or we can also call it biconvex appearance will be there. What are the special point about it? You will be having, patient will be having lucid interval. Lucid interval matlab there will be a period of consciousness, then there will be a period of consciousness between subconsciousness. That is going to be your lucid interval. You will also study about this lucid interval in the psychiatry, right? In the Psychiatry in the schizophrenia, right? So special point that there will be lucid interval. Okay, and one more question they have asked from the anatomy, that is going to be the site. What is the site? The site will be pterion. The site will be pterion. Very, very important, right? How you are going to treat this particular thing? How you are going to treat this particular thing? You can do burr hole surgery. Burr hole surgery. Burr hole surgery for the cases of ADH. Now, second, let's discuss about the SDH. In SDH, where will be the rupture? The rupture is important. The rupture will be in the emissary bridging veins. The rupture will be in the emissary bridging veins. And here you will be having which shape? You will be having banana sign. Banana sign, you can also call it crescent. Crescentic lesion, moon-like lesion, half moon-like lesion will be there. Okay, remember, this is the only hemorrhage which is going to have venous involvement. This is the only venous hemorrhage that we are having. This is the only venous hemorrhage we are having, that is going to be your SDH. And this venous hemorrhage we are going to treat with the help of, we just want to decrease the pressure, we are going to use mannitol. Here in this case we can use osmotic things, that is going to be your mannitol, right? Now you will be helping me to write this particular thing down about the SAH. Here you will be having rupture of berry aneurysm. Just now we have seen berry aneurysm, right? Here you will be having accumulation of fluid in the sylvian fissure, and basal cisterns, right? This is going to be the worst headache. What is the classical thing you will be getting in the question? Keyword is going to be worst headache of my life. Worst headache or thunderclap headache. Thunderclap headache or worst headache of my life. If they give you in the question, you will be jumping directly to this particular answer, right? What is the drug you will be using here? Here you will be using beta nimodipine, right? Nicardipine कहाँ यूज में लेंगे? Let's discuss. Okay, let's discuss about that. Next we are having is ICH. This is going to be intracerebral hemorrhage will be there, right? What is going to be the most common artery that is going to damage? Here is going to be your lenticulostriate artery. You can also call it Charcot artery. Is the most common site of damage, right? Apart from that, here you will be having midline shift. Here you will be finding midline shift on the ventricles. Apart from that, here you will be having intracranial space occupying lesion. Intracranial space occupying lesion will be there, right? What is the most common site? Most common question they are asking. The most common question they are asking, there is a person, there is a male patient and he is hypertensive and he is having acute bleed, hypertensive acute bleed. What is the most common site? What is the most common site for acute hypertensive bleed? Try to answer. That is going to be your putamen beta. Most common site is going to be your putamen. So whenever you are getting a question on hypertensive patient, you have to think in the terms of putamen bleed. And in this particular case, the drug of choice will be nicardipine. यहाँ देंगे nicardipine. Okay, you can simply remember cerebral. Intracerebral में क्या देंगे? C for C, you can remember like that. So intracerebral you will be using what? Nicardipine. Nimodipine you will be using in the cases of subarachnoid hemorrhage. In the cases of SDH you will be using mannitol. In the cases of EDH you will be doing the burr hole surgery, right? All these are your arteries. The only venous hemorrhage they can ask you. The only venous hemorrhage that is going to be your subdural one, right? These are going to be the images. This is going to be your epidural, lemon shape. This is going to be your banana shape, that is going to be your subdural. This sylvian fissure basal cistern is going to be in the favor of subarachnoid hemorrhage. In the cases of ICH, what you need to remember, It is going to be the most common site. The most common site itself is, it is the most common site. Look here, this is the most common site. You can also appreciate, I've taught you, you will be having midline shift. Can you appreciate, this is the midline shift we are having of the ventricle, right? This is what we have studied, right? Here you will be finding the midline shift also, right? So in this particular thing, this is your putamen, this is your putamen bleed, and this patient will be what, if you go back on history without looking at the image, you will be finding this is a hypertensive patient who is not continuing the medicine, and suddenly he has developed this type of hemorrhage, he is having hemiplegia or something like that, right? These things, these symptoms will be there, right? You understand? So this is going to be your intracranial hemorrhage. So in this particular case, now I hope you know what is extradural, what is subarachnoid, what is subdural, what is intracerebral. Just go through this particular PDF just before your examination. I've covered most of the important point that will be high likely to be asked in your exam, right? Now the next question that we are having, a 36-year-old lady is presented to you. Now a 36-year-old lady is presented to you with generalized muscle weakness. This patient is having muscle weakness, drooping of eyelids, double vision, that is diplopia, that worsens with the activity and improves with the rest. Very, very classical statement, right? She has difficulty in chewing and swallowing in the evening hours. In the evening hours, she is having difficulty. Tensilon test, all the clues are given. All these are the buzzwords, okay? Tensilon shows improvement in the muscle power, okay? Tensilon shows improvement in the muscle power, which is the most sensitive test for diagnosis. Your previous year exam question, last exam question, this is the question they have asked you. Remember guys, the diagnosis in this particular case is, you cannot skip this topic. Myasthenia gravis, last 3 to 4 exam, if you see, you will get 2 to 3 questions in every exam from myasthenia gravis, right? You cannot skip this, myasthenia gravis. So this is the thing we are having, myasthenia gravis. And what is the thing you will be doing? Janvi, I have already taught you about the meningitis in the previous question. You can rewatch the videos, right? So we are having this particular thing. This is going to be your single fiber electromyography. This was the previous year question. Let's try to understand what is this myasthenia gravis and how what are the different tests that we are going to do, right? So myasthenia gravis. So let me write down myasthenia gravis. What are the antibodies? Try to answer till then. Is it going to, first of all, tell me, is it going to be a type 2 hypersensitivity or a type 3, or which kind of hypersensitivity it is? Whatever you know till then, try to write down about the myasthenia gravis. It is going to be a type 2 or type 5 hypersensitivity reaction. If type 5 is given, Graves, 2 Graves you can remember. One is Graves disease, second one is your myasthenia gravis. Otherwise they are type 2, right? This is going to be hypersensitivity reaction, right? Apart from that, what is going to happen here? You are going to have nerve. Suppose this is your nerve, and from the nerve you will be having release of acetylcholine, and this acetylcholine will be going to the receptor, and this is your muscle, right? Now what is happening here? You are going to have what? Auto antibodies. Listen to me and write what you know. Now you are going to have auto antibodies. Auto antibodies are formed against what? Auto antibodies are formed against these receptors. So what are the different names of these auto antibodies? We are having anti-acetylcholine receptor antibody. We are having anti-acetylcholine receptor antibody. We are having neuromuscular junction, so we can have anti-musk antibody. NEET PG previous year question, anti-musk antibody. And one more you can remember, anti-LRP4 antibodies. Anti-LRP4 antibodies. They can give you a question, the question they have asked you, like, all of the following are the antibodies of myasthenia gravis, right? All except. They can give you options like all except. So these 3 names you have to remember: anti-acetylcholine, anti-musk, anti-LRP4, right? Second question they have asked you based on this, what is the most common association? So remember, this is going to be associated with the tumor, that is present in the anterior mediastinum. What is the most common anterior mediastinum tumor? What is the most common tumor that we are having? We are having anterior mediastinum tumor. right? That is going to be thymoma beta. Thymoma, thymic hyperplasia, thymoma, very very important question. They can give you x-ray of the image. They can give you x-ray, frontal x-ray, lateral x-ray. They will be showing you some tumor in the anterior mediastinum, and they can ask you question about the myasthenia gravis. Remember this particular point, thymoma. Okay, what is the most common symptom beta? Most common symptom will be, you will be having bilateral ptosis will be there. Bilateral ptosis will be there. And what is the best test that we can do? This was your previous year question, previous exam question. This is going to be single fiber electromyography. This was the question that they have asked you. That is going to be the best test that we can do. We can also do, yes, you have written, that is ice pack test. We can also do ice pack test. We can also do test to differentiate between cholinergic crisis. That is going to be your adrophonium test. Adrophonium. Or we can also do tensilone test. Tensilone. Okay, tensilone. Apart from this, we can also do repetitive nerve stimulation test. But remember what this is going to show. Stimulation test, from the morning till the evening, whenever you are going to stimulate the receptor, they are going to show the decremental response. Remember, here you will be getting the decremental response. So if they talk to you in the sense that the person is okay in the morning, and as the day passes, what will happen? The disease is progressing. That is going to be in the favor of myasthenia gravis. Myasthenia gravis, right? What is the drug of choice? You can use drugs like pyridostigmine. You can also use steroids. Okay, we can do other things also, like we can also do plasmapheresis. Just remember these things. Or sometimes they can ask you about the thymectomy also. Thymectomy. For the treatment, we can also do the thymectomy. These are the important points that you need to remember about the myasthenia gravis, right? So what is the test that we are going to do? This is going to be beta single fiber electromyography. Very very important topic. You cannot skip this, right? Very very important. Definitely you will be getting question from here, right? Next question we are having, a 62-year-old male patient is presented to the emergency with the acute onset of following symptoms. What are the symptoms the patient is having? The patient is having right face drop. He cannot speak clearly. And along with that, right sided hemiparesis. What is hemiparesis? What is quadriparesis? Okay, he was a known case of hypertension. Now you are going to the diagnosis. On the basis, on the examination, we are having BP. What is the BP we are having over here? 220 by 110. The NCCT of head is shown below. All of the things can be done to manage this patient except. So this is not just the question. This is the type of patient you will also see in the OPD. When you pass your exam, I hope all of you will pass your exam, then you come to the hospital for internship, you will be finding a patient, 60 to 65-year-old patient is coming to you. Maybe nowadays young patients are also coming. They are coming to you. The patient will be having high BP. He is a case of hypertension. He is not taking the tablets, and right now he is having face drop or hemiparesis will be there. And now you will be identifying what kind of a stroke, what kind of a thing will this patient is going through, and then you need to know how you are going to manage it, right? So what do you think, what is going to be here? So this is a basic case of stroke. So what is the provisional diagnosis that you will make? That is going to be your stroke. Okay, tell me, what is hemiparesis? What is hemiparesis? What is paraparesis? These terms should be clear to you. Paraparesis. What is quadriparesis? Okay, so hemiparesis means half of the body, one side of the body is gone. That is going to be your hemiparesis. The paraparesis will be two limbs. Maybe the both hands are not working. That means two limbs are not working. Okay, quadriparesis मतलब क्या हो गया? All the a pair of limb in the paraparesis. Okay, and in quadriparesis all the limbs are not working. All the limbs not working. Okay, Not working means not completely not working. There can be weakness, there can be weakness, there can be tingling, there can be paresthesias, tingling, tingling sensation, there can be paresthesias, there can be weakness. All these things are the symptoms of stroke, right? Another thing that is given here I want to talk about, that is going to be your hypertension. This patient is hypertensive, the BP is 220 by 110, right? The two hypertension we are having, one is hypertension emergency, another one is hypertension urgency. What is the difference? Which one is going to have what? Which one is going to have end organ damage? Hypertensive emergency, we are having hypertensive urgency. Tell me beta, which one is going to have the end organ damage? Both of them are going to have high pressure, both of them are going to have high pressure. Here you can see that midline shift is there. Okay, in hypertensive emergency we are going to have end organ damage. Emergency we are going to have end organ damage. Very good. Urgency we are going to have no end organ damage, right? So this is how we are going to understand. This is a lesion, and the lesion is in the putamen. Where is the lesion? We are having putamen, and you can also appreciate the midline shift. So this is a case of ICH. Please try to tell me, how would you like to manage this patient? How would you like to manage this patient? Are you going to do thrombolysis? Are you going to give labetalol or cerebral edema you will try to manage, or you can give the hyperventilation to the patient? What you would be doing in this particular patient? Lavanya, and urgency will be having no end organ damage. Emergency will be having end organ damage. Emergency में क्या होता है? Emergency ज़्यादा खतरनाक होती है, right? So in emergency we are having end organ damage. Emergency मतलब कोई admit है. Urgently अगर कुछ चाहिए, that is not going to be the same thing, right? Okay, so let's try to proceed how you are going to manage a patient of stroke, and this is how they are asking you the question. I'm not going to, the table is very difficult in Harrison, I'm just trying to simplify it for you. Okay, so just try to see it. So stroke, two possibilities can be there in the stroke. First thing can be, there can be a temporary episode, like we are having angina in the heart. Same wise we are having what? Transient ischemic attack. On transient ischemic attack, we can have transient ischemic attack, and second thing we can have stroke. Stroke is also known as cerebrovascular accident, CVA. We can also call it what? CVA. This transient ischemic attack, remember this is happening within 24 hours. 1 to 24 hour के बीच में जो भी हो रहा है, that is going to be 1 to 24 hours, it will be getting resolved. That is known as transient ischemic attack. Let's say weakness आई थी, but it will be resolved within 1 to 24 hours. That is going to be in the favor of transient ischemic attack. On radiology, are you going to find any sign? You will not find any sign. No sign will be there on radiology. Reason being, just like in angina there is no complete infarction, right? So we cannot find trop T or trop I. जब तक कोई rupture नहीं होगा, जब तक कोई infarct नहीं होगा, we are not able to, जब तक कोई cell नहीं टूटेगा, we are not able to find the enzymes. Same thing is happening here. This is a transient ischemic attack. थोड़ी देर के लिए ischemia हुआ, oxygen नहीं मिला, right? So you will be having no signs of infarct will be there. Okay, no sign of infarct will be there. But the question that they have asked you, how you will assess that this particular patient will be having infarct in the near future. This patient is going to have stroke in the near future, और उसके लिए एक scale होता है. What is the score system that we are checking? So for the risk of stroke, we are having a scoring system, and what is the score that we are using? That is your ABCD2 score. That is your ABCD2 score. The score that we are using for this particular thing is your ABCD2 score. ABCD2 score. A for there will be age, B for BP component पूछ सकते हैं, C for you will be having clinical features, D for first D is going to be the duration, and second D is going to be the diabetes mellitus. If the patient is having diabetes mellitus, that is the risk factor. That is a risk factor. This is the question, previous year question they have asked you, right? Now in the cases of stroke, sorry, in the cases of stroke, if it is more than 24 hours, signs and symptoms are present. if signs and symptoms are present for more than 24 hours, you will be having infarction, and now you are going to proceed for the treatment, right? So how you will understand that particular person is going under stroke, right? For that we are having a sign, for the suspicion, we are having a sign that is fast. F4, if there is any kind of focal neurological deficit, if any kind of focal neurological deficit is present. A4, if any arm weakness, अगर ऐसा कुछ हो रहा है, any arm weakness is noted. S4, there will be problem in the speech. If there is any problem in the speech. And T4, this is the time to call the ambulance, time to call the help. So this is the fast that we are going to do for the suspicion of stroke. If someone is having focal neurological deficit, any weakness in the arm, any side weakness, speech problem, the patient can have Wernicke's or Broca's aphasia, anything can be there, right? Global aphasia, fluent aphasia, I've taught you in the physiology section, right? So if patient is having any of these symptoms, you will be thinking in the terms of stroke, and you will be taking the patient to the hospital, right? In the hospital, first thing they will be doing, they will be checking for the airway, breathing, circulation management. After that, they will be doing the NC-CT scan of the patient, right? After NC-CT scan, we will identify whether the stroke can be hemorrhagic, stroke can be ischemic. Okay, two possibilities can be there. Either the stroke can be hemorrhagic, beta, either the stroke can be ischemic. स्ट्रोक या तो हीमरेजिक हो सकता है या इश्कीमिक हो सकता है. फॉर द हीमरेजिक स्ट्रोक व्हाट यू विल बी हैविंग, द पेशेंट विल बी अ हाइपरटेंसिव पेशेंट. तो पेशेंट में क्या मिलेगा, हाइपरटेंशन मिलेगा. जो बीपी होगा दैट वुड बी मोर देन 160/100. द बीपी विल बी मोर देन 160/100. okay, and the most common site you already know, for the hemorrhagic stroke the most common site will be putamen. हाइपरटेंसिव स्ट्रोक के लिए मोस्ट कॉमन साइट क्या है, putamen, right? For the treatment of this hemorrhagic stroke, what you are going to do, you are going to control the BP of the patient. Okay, you are going to control the blood pressure. The pressure in the brain will be high because of loss of fluid, loss of blood. So you are going to manage that. You are going to decrease the intracranial pressure. Remember, here you are not going to use what is contraindicated, your alteplase, it is contraindicated. Your thrombolysis is contraindicated. बात समझ में आ रही है? अगर किसी भी पेशेंट को, लेट मी समराइज इट फॉर यू, किसी भी पेशेंट को स्ट्रोक हुआ है, फर्स्ट ऑफ ऑल यू विल आइडेंटिफाई वेदर इट इज अ हीमरेजिक स्ट्रोक, वेदर इट इज अ इश्कीमिक स्ट्रोक. इफ इट इज अ हीमरेजिक स्ट्रोक, ब्लड दिखेगा ब्रेन में, राइट? अगर वहां पर सीटी में यू आर फाइंडिंग द ब्लड, यू आर नॉट गोइंग टू गिव व्हाट, you are not going to give thrombolysis or alteplase. Alteplase is basically going to do what? Thrombolysis, right? So this was our question. This is a hypertensive patient. We already know this is a hypertensive patient. What kind of a stroke is this? This is a hypertensive stroke. So what you are not going to give here, the question is asking, you can do all of the things, all of the following things can be done to manage this patient's, एक्सेप्ट व्हाट शुड नॉट बी डन. दिस इज योर प्रीवियस ईयर क्वेश्चन. क्या नहीं करना है इस पेशेंट में? रिमेंबर गाइस, थ्रोम्बोलाइसिस नहीं करना है. This patient should not be, we should not do the thrombolysis in a patient of hemorrhagic stroke. This is the main important point I want you to understand. You can use IV labetalol, you can decrease the intracranial pressure, you can give the ventilation, you can give the oxygen to the patient, ABC maintain करना है, right? But you are not going to do what? Thrombolysis in the patient. Question was easy, just you need to develop the understanding, right? अगर ट्रांजिएंट इस्केमिक अटैक है, द स्कोर दैट वी आर यूजिंग इज ABCD2 स्कोर. अगर स्ट्रोक है पेशेंट के अंदर मोर देन 24 आवर्स के लिए, FNDF, वोकल न्यूरोलॉजिकल डेफिसिट, व्हाट इज गोइंग टू डू? आइदर इट इज हिमरेजिक का ट्रीटमेंट हमने देख लिया. नाउ वी आर गोइंग टू सी इफ इट इज अ स्कीमिक स्ट्रोक. इफ इट इज अ स्कीमिक स्ट्रोक एंड द पेशेंट इज गोइंग टू reach to the hospital within 4.5 hours. If we are taking the patient within 4.25 hours, what we need to do, we need to do first thing, that is going to be your thrombolysis. In this particular case, we need to do thrombolysis. We can use alteplase here, alteplase, reteplase, tenecteplase, whatever is available we can use, right? This is the approach for the patient which is arriving in the hospital within 4.5 hours. If the patient is arriving more than 6 hours, then we need to do the MRI. And after MRI, what we will be doing now, we will be doing thrombectomy, mechanical thrombectomy we will be doing, or after thrombectomy we will be doing endoscopic, you can remember endovascular revascularization. So this is going to be the approach, right? Now we are going to do endovascular revascularization. If the patient is coming late to the hospital, like after 6 hours, that is going to be thrombectomy. We can do thrombolysis, we can do till 4.5 hours. In certain books it is written more than 4.5 also, but just remember 4.5. Less than 4.5 would be a good thing, right? So this is how we are going to manage the case of ischemic stroke and hemorrhagic stroke. Ischemic stroke and hemorrhagic stroke. Hemorrhage में क्या हुआ? Just try to understand this. यहाँ पर कोई भी clot बना हुआ है. Here we are having any clot in the blood vessel. What is going to happen? You can have two important things. One thing, suppose this is your tissue. Now what is happening? The oxygen is not reaching to the tissue. What we need to do? We need to thrombolyze. We need to do the thrombolysis. We need to remove this clot. This is what we are doing in the cases of ischemic stroke. It will regain the supply. Second thing, what is happening? Because of some rupture, what is happening? There is the blood is oozing out. Because of some rupture. So first thing you need to do, you need to decrease the BP. You need to decrease the tension that the brain is having. Because of excess of fluid, what will happen? The intracranial pressure will be increased, right? So you need to decrease that intracranial pressure. This is what you need to do, right? All right, next question we are going to have. A 65-year-old male patient is presented to you with the complaints of tremor. The patient is having what? Tremors, along with the slowness of movement. Will be there. Micrographia. Later on, he is prescribed some drugs which is working by increasing dopamine receptor. So you need to identify what is the disease. First of all, tell me what is the disease that you are suspecting. Micrographia मतलब क्या हो गया? Handwriting क्या हो गई? छोटी हो गई, small writing. That is going to be your micrographia. कुछ लोगों को दिख नहीं रहा, they will be thinking like that. Okay, that is your micrographia, है ना? I'm completely fine. Okay, so we are having this micrographia, and the diagnosis in this particular case, what do you think? What is your diagnosis? Very good. Very good, guys. This is the case of Parkinson. What are the important symptoms we are having in the Parkinson? The symptoms we are going to have is tremors. Patient will be having pin rolling, resting tremors will be there. Rigidity will be there. Patient will be taking baby steps, right? He will be having bradykinesia, slowness of the movement. Bradykinesia. The face will be mask-like faces will be there. Okay, mask-like faces. So these are the symptoms, right? These are the classical triad we are having in the cases of Parkinsonism, right? This is the diagnosis. The diagnosis is going to be your Parkinson disease. What will happen in Parkinson disease? Remember, I have told you in psychiatry also, we are having decrease in the dopamine receptor. In which pathway? Thank you, guys. Thank you. You made my day. I hope all of you will pass with the flying colors. Okay. I'm also working hard. You are also working hard. So everything will pay off, right? So in Parkinsonism, what is going to happen? There will be decrease in the dopamine. there will be decrease in the dopamine will be decreased in multiple pathways. I've taught you about 4 pathway: mesolimbic, mesocortical pathway, nigrostriatal pathway, right? Tuberoinfundibular pathway. देखो फटाफट verbal explanation देता हूँ. Tuberoinfundibular में कम होगा dopamine. What is going to happen? It is also known as prolactin inhibiting hormone, right? Mesolimbic is going to be concerned with which kind of symptoms? Positive symptoms. Mesocortical में अगर कम होगा तो negative symptoms आएंगे, psychiatric के negative symptoms like asociality, apathy. Okay, mesolimbic, right? And lastly we are having nigrostriatal pathway. अगर उसके अंदर dopamine कम होता है, what is going to happen? You are going to have Parkinsonism, right? So decrease in dopamine in nigrostriatal pathway. Nigrostriatal pathway, बेसल गैंग्लिया के अंदर नाइग्रोस्ट्राइटल पाथवे में कम हो जाएगा तो पेशेंट विल बी हैविंग स्लोनेस ऑफ मूवमेंट, ट्रेमर्स, रिजिडिटी, ब्रेडिकाइनेसिया, मास्क लाइक फेसेस विल बी देयर, राइट? व्हाट इज द जीन दैट इज इन्वॉल्वड हियर? दैट इज गोइंग टू बी अल्फा synuclein. And what are the bodies that you will be finding in the pathology? You will be having the bodies, these are going to be your Levy bodies, right? So these are the important things. Now let me make you understand about the treatment, how we are going to treat this particular disease. For the treatment, simple understanding, what is the neurotransmitter that is going to make the dopamine, right? So everything is going to form from the tyrosine. It is going to make the dopamine, and this dopamine is going to get stored in the neurons in the form of vesicles, right? Now what is going to happen? These vesicles will be coming out and they are going to go for the receptors. We are going to have these receptors, right? And this is going to be breakdown with the help of MAO and COMT. These are the things which are going to break this dopamine down, right? Now what we need to do, we need to understand what we need to do, our aim. What is our aim here? To increase dopamine in the nigrostriatal pathway. We just need to do increment in the dopamine in nigrostriatal pathway. This is our aim. So how we can increase that dopamine? First thing, we can give a drug which is just like dopa, right? Just like dopamine, right? That is going to be your levodopa. We are giving with carbidopa. So this is going to be carbidopa is deep dopa decarboxylase inhibitor. जो भी levodopa हम दे रहे थे वो शरीर में टूट जा रहा था बाहर से, तो हमने क्या किया? कार्बिडोपा दे दिया. That is going to block that particular enzyme which is killing the levodopa. अभी सारा levodopa कहाँ जा रहा है? ब्रेन में जा रहा है, right? Second drug we are having is going to be ropinarole, pramipexole, ये वाली जो दवाइयाँ, right? They are going to increase the they are basically D2 receptor agonist. Okay, so second thing what I can do, I can increase these receptors. I can increase this receptor, directly stimulate these receptor. What is going to happen? You will be having increase in the dopamine function, and this is the drug of choice. In fact, this is the drug of choice. Ropinarole, pramipexole, they are the drug of choice. Apart from that, we are also having other drugs like amantadine. थोड़ा सा क्विक रिव्यू दे देता हूँ. amantadine we are having. amantadine क्या करता है? These vesicles we are having, dopamine vesicles. It is basically an anti-influenza drug. What it is going to do? It is going to increase the vesicles. ये vesicles अंदर से बाहर फेंकेगा. What will happen? Here you will be having increased levels of dopamine. That is what we want, right? So amantadine is going to increase the release of dopamine. It is going to increase the release of dopamine vesicles. Okay, then we can block these enzymes MAO and COMT. ये क्या करते हैं? इस डोपामिन को तोड़ देते हैं. हम क्या चाहते हैं? यहाँ पर डोपामिन बढ़ा रहे. So what we are going to do? We are going to block MAO and COMT, right? So we are having MAO inhibitor. Or basically this is present in brain, so we are having MAO B inhibitor. MAO A is going to present at all places. This is your MAO B inhibitor. Previous year question, selegiline. Selegiline is a MAO B inhibitor. Okay, and lastly we are having COMT inhibitor. That is going to be your entacapone. Okay, repeat with me. Selegiline is a MAO B inhibitor. COMT inhibitor is going to be your entacapone. Ropinarole, pramipexole, that is going to be for the dopamine receptors, right? So look here, selegiline, entacapone, ropinarole, levodopa. Now you have to answer, which of the following drug is working by increasing the dopamine receptor? Dopamine receptor कौन बढ़ा रहा है? Yes, try to answer. Which of the following drug is going to increase the dopamine receptor here in this particular case? Yes, that is, yes, Lavanya, we are having cheese reaction. We are going to give phentolamine in that particular case. Here, here it is going to be ropinarole. Ropinarole, in fact, ropinarole and pramipexole are the drug of choice for Parkinsonism nowadays, right? So we are using that. Why B? Dopamine receptors, these are the drugs which are going to work on the receptor. Entacapone is going to work on the COMT. Okay, just go through this particular PDF, you will be able to understand. Okay, एक बार देख लेना. I will be sharing the PDF in my Telegram group, you can join. Okay, next question we are having. A 29-year-old male patient is presented to emergency. The patient is presented to emergency with the symptoms of, what is the complaint this particular patient is having? Weakness in both the legs, which is progressing upwards. This weakness is progressing upward. On examination, the patient had a history of dysentery. Very, very important. Dysentery history, right? Few days ago, what is the most probable diagnosis in this particular case? Yes. What is the most probable diagnosis in this particular case? So there is a history of dysentery which is given. History of dysentery. Dysentery से क्या याद आता है? What you remember? Shigella. But remember in micro I have taught you, right? Shigella के अलावा एक और पढ़ाया था. What is that? Yes, very good. That is going to be your Campylobacter jejuni. Campylobacter jejuni. Campylobacter के ऊपर एक और क्वेश्चन है previous year. That is going to be, which is the media we are going to use. That is going to be your Schiromedia. Schiromedia. Okay. So this is your Campylobacter jejuni. And what is this question is suggesting? Patient को क्या हो रहा है? Weakness in both the legs, which is progressing upwards. So we are having bilateral, both the legs matlab bilateral, symmetrical. Can I call it symmetrical? Yes, this patient is having bilateral, symmetrical. The weakness is progressing upwards. That means it is a ascending type of paralysis. So if the patient is having bilateral, symmetrical, ascending type of paralysis, and what kind of paralysis it is going to be? It is going to be flaccid paralysis. Flaccid paralysis. This is going to be in the favor of what? This is going to be in the favor of Guillain-Barré syndrome. Guillain-Barré syndrome, very, very important topic, right? GBS. Now, what is this? What is this flaccid or what is this spastic paralysis? What are the lesions? Let me revise it for you. Physio में पढ़ा है. Let me revise it again. Upper motor lesion अगर होगा, remember upper motor lesion अगर होगा, you will be having always increase in the deep tendon reflex. ऐसे याद रख लो, deep tendon reflex पड़ेगा, and you will be having one sign positive, that is going to be your Babinski, and this is going to be your spastic type of paralysis. Spastic. If the lesion is in the lower motor neuron, there will be decrease in the deep tendon reflex. There will be negative Babinski. Babinski मतलब वो पैर के वो, and this is going to be showing you which kind of paralysis. This is going to be बेटा flaccid type of paralysis. यहाँ पर क्या होगा? Movement नहीं होगा, deep tendon reflex कम हो जाएंगे, everything will be flaccid. Okay, that is going to be your lower motor neuron lesion, right? Now let me make you understand about the GBS. What is this GBS? And the most common type of GBS is going to be your acute. It is going to be acute inflammatory demyelinating polyneuropathy. Okay, AIDP भी बोलते हैं इसको. We also call it AIDP. This is the most common one, most common variety. Okay, the antibody that they will be asking you, this is going to be your anti-GM1 antibodies. This is going to be your anti-GM1 antibodies. Very, very important, you have to remember. Okay, anti-GM1 antibodies are going to be present over here, right? For diagnosis on lumbar puncture, we are going to do what? We are going to take this sample from the lumbar puncture, and now we are going to find what here, very, very important, that is going to be your albuminocytological dissociation will be there. If you see this word albuminocytological dissociation, you will be thinking in the terms of Guillain-Barré syndrome. Guillain-Barré syndrome. Okay, it will sometimes it will have nerve involvement. The most common nerve involvement will be that is going to be your facial nerve. And remember, in GBS you will be having what? In GBS you will be having sparing of bowel and bladder. इनमें दिक्कत नहीं आएगी. Bowel, bladder. Yes, treatment की if बात करो, treatment you will be giving intravenous immunoglobulins, or sometimes you can also do plasmapheresis. एक क्वेश्चन में they have given you the is there any role of steroids? No, remember there is no role of steroids. Okay, no role of steroids. All except question है there will be no role of steroids. Okay, there will be no role of steroids. Next syndrome that we are having. So you understand what is Guillain-Barré. Now we will be discussing about this Miller-Fisher syndrome. What is this Miller-Fisher syndrome? कौन सी एंटीबॉडी होती है यहाँ पर? Here you will be having anti-G1Q antibodies. इतना याद रख लो, anti-G1Q antibodies. और इसका एक ट्राइड होता है, ट्राइड बोलता है आओ, right? That is going to be AAO. What is the triad? A for you will be having ataxia. Ataxia generally seen in the cerebellar lesions, right? You will be having areflexia, and you will be having ophthalmoplegia. That is going to be your Miller-Fisher syndrome. And this disease, amyotrophic lateral sclerosis, which is the famous personality you know with the amyotrophic lateral sclerosis. Okay, कहाँ म्यूटेशन होता है ALS में? The mutation will be present in which gene? Okay, it is a type of UMN plus LMN, both palsy will be there. और यहाँ पर ना पेशेंट को एक अलग तरीके की स्माइल आती है, दैट इज नोन एज वेरी गुड. यू हैव सीन स्टीफन हॉकिंग, ही वाज ऑलवेज स्माइलिंग, हिज फेस वाज लाइक स्माइलिंग, राइट? दिस इज नोन एज पैथोलॉजिकल स्माइल. ओके, स्टीफन हॉकिंग को थी ये डिसीज, स्टीफन हॉकिंग, राइट? what is the mutation that you will be having over here? क्यों होती है ये डिजीज? दिस इज बिकॉज ऑफ SOD. Okay, so superoxide dismutase, SOD1. Yes, SOD1, right? That is going to be SOD1, right? For the treatment we do not have specific more treatment, but we can use riluzole. We can also use idaruone. ये दो ही चीजें याद रखनी है, riluzole और idaruone. Okay, why polio is not the answer here? देखो, पोलियो का जो पैरालिसिस होता है, इट इज गोइंग टू बी योर acute flaccid type of paralysis. Yes, but it is a descending type of paralysis. यहाँ क्वेश्चन में हम लोगों को क्या दे रखा है? They have asked about the ascending type of paralysis. Polio will be having descending type of paralysis, right? So polio cannot be the answer. Miller-Fisher cannot be the answer. ALS, there will be both upper and lower motor neuron palsy. So answer in this particular case will be Guillain-Barré syndrome. I hope this is clear to you. Okay, दो तीन चीज़ें याद रखनी है इसके बारे में, जस्ट रिवाइज विद मी. ओके, GBS में कौन सी एंटीबॉडी मिलेगी? दैट इज गोइंग टू बी योर anti-GM1 एंटीबॉडी. Albuminocytological dissociation will be there, facial nerve involvement, and it is not going to affect your bowel and bladder, right? IVIG देंगे, plasmapheresis करेंगे. Miller-Fisher में anti-G1Q एंटीबॉडी, here anti-GM1. ओके, GM1 गैंग्लियोसाइड हम लोगों ने पढ़ा था कोलेरा टॉक्सिन में, राइट? यू कैन रिमेंबर anti-GM1 एंटीबॉडीज आर सीन इन Guillain-Barré syndrome, right? Anti-G1Q is going to be in the Miller-Fisher. Amyotrophic lateral sclerosis, SOD mutation will be there, right? And polio will be having acute flaccid paralysis. Okay, now very simple question. If you understand this particular image, the answer is direct. Like if you remember the radiology as well. A 45-year-old female patient is coming to the hospital with the symptoms of paresthesia. This patient is having what? Paresthesia. Okay, with and pain with the weakness, right? She is also having visual issues, she is also having the visual disturbances. And on reference we are getting a pupil. In ophthalmology, what is this Marcus gun pupil? What is this Marcus gun pupil? Some of you are answering. What is this Marcus gun pupil? Right? Marcus gun pupil is noted and MRI is prescribed. MRI head में क्या मिल रहा है? You are finding this particular image. You are finding this particular image. This is your around the ventricles. You are having what? You are having periventricular. You are having this periventricular lesions. And what is this periventricular lesions are known as? These are known as Dawson fingers. These are known as Dawson fingers. Can you appreciate? This is your ventricle. Around the ventricle you are finding these lesions. These are looking like fingers, right? These are known as Dawson fingers. These are known as Dawson fingers. And what is this Marcus gun pupil? This is also known as RAPD. This is also known as RAPD. RAPD is relative afferent pupillary defect. This is also known as prostitute's pupil. Prostitute's pupil. है ना? This is also known as prostitute's pupil, right? Question simple आते हैं. The question in the exam, they are simple. If you understand how to pick up the keywords, the question will be simple. Okay, यही चीज़ें बार बार पूछते हैं, right? So for the diagnosis, what is the diagnosis? Okay, what kind of question they will be asking you? They will be asking you एक क्वेश्चन कैसे बनाते हैं. They will be giving you some middle aged female दे देंगे. Okay, this particular female will be having paroxysmal paresthesias. This particular female, they will be writing paroxysmal paresthesias will be there, right? Sometimes they can write you about the vision loss, or they can also write you about the optic neuritis component दे देंगे. Okay, this is, we already know, this is going to be a demyelinating disease. और अगर फिजियो से क्वेश्चन बनाना होगा, if they want to ask you question from the physiology, they will be writing you myelin basic protein defect, right? We have already discussed this. This is going to be your multiple sclerosis. All these things are going to go in the favor of multiple sclerosis. Sir, myasthenia gravis, we have already seen, this cannot be the answer. Alzheimer's, sir, cortical atrophy will be there, multiple things will be there. I'm going to teach you what is this CJD, Creutzfeldt-Jakob disease. This is a Prine's disease. Let's discuss about it. First, one more question they have asked. Let me write it about for you. For the diagnosis, we are using a special criteria that is known as McDonald's criteria. McDonald's criteria. What is the criteria we are using? McDonald's criteria, beta. We are using a special criteria that is going to be your McDonald's criteria, right? So Marcus gun pupil, this RAPD, prostitutes pupil diagnosis, you will be going in the favor of multiple sclerosis. Okay, so मल्टीपल स्क्लेरोसिस के ऊपर जो क्वेश्चन ये लोग पूछते हैं, द क्वेश्चन इज बेसिकली बेस्ड ऑन द ट्रीटमेंट पार्ट. दे वांट टू नो अबाउट द ट्रीटमेंट, राइट? सो फॉर द acute multiple sclerosis, what you will be doing, this myelin basic protein is responsible for the स्फिंगोमाइलिनेशन. जो स्फिंगोमाइलिन फॉस्फोलिपिड होता है वो क्या करते हैं? न्यूरॉन्स का माइलिनेशन करता है. इफ न्यूरॉन्स आर माइलिनेटेड, दैट मीन्स दे आर गोइंग टू हैव फास्टर कंडक्शन वेलोसिटी. माइलिनेशन का मतलब क्या हो गया? सपोज दिस इज अ न्यूरॉन, इसके ऊपर जितना माइलिन होगा ये उतना ही फास्टर न्यूरॉन होगा. इट इज गोइंग टू बी द फास्टर न्यूरॉन. विच इज द फाइबर, विच इज द फास्टेस्ट फाइबर वी आर हैविंग? ट्राई टू आंसर. Okay, let me see if you remember which is the fiber, which is the fastest fiber we are having. A alpha, A beta, A gamma, A delta. What is going to be that? B or C, right? So what is going to happen for the treatment? Look at beta, we are going to do in the cases of, first thing, for the acute cases we are going to give steroids. That is going to be nothing but your methylprednisolone. For the prevention of the disease, we are going to use a monoclonal antibody, that is going to be your natalizumab. natalizumab. And the most effective drugs that we are having, effective drugs if they ask you, that is going to be your CD20, that is going to be your rituximab, ocrelizumab, ocrelizumab, and siponimod. Siponimod. Right? These are the drugs we are going to use in the cases of multiple sclerosis. Multiple sclerosis. Okay. What is this Prine's disease? Yes, siponimab or fingolimod, we can, both of them we can use. Fingolimod we can also use. Fingolimod we can also use. Right? So that is going to be the treatment for the multiple sclerosis. Now the next thing we are having is the Prine's disease. So basically, what is a Prine's? Prine's is basically, it is a type of infectious proteins, misfolded infectious proteins. I've told you in physiology how these proteins are formed, how these proteins are folded, how these are transported, right? If there is abnormal protein folding will be there in the body, they will get deposited in the body. Like we are having amyloid protein deposition, that would be causing the next disease, that is going to be your Alzheimer, right? तो यहाँ पर भी क्या होता है ना, PRP प्रोटीन होता है, वो PRP-SC में कन्वर्ट हो जाता है, that is going to be known as scrappy. And now this scrappy will get deposited on the brain, and this is going to cause the disease. In humans, it is going to cause a disease that is known as Creutzfeldt-Jakob disease. Most common disease in human, that is going to be kettles वगैरह में होते हैं, that kuru that you are talking about, that is going to be in the kettles, right? So this is going to be Creutzfeldt-Jakob disease. Here you will be having spongiform encephalopathy. Spongiform encephalopathy. Can anyone tell me about the treatment of this particular disease? Okay, most common, it is going to be sporadic. हाँ, इसके ऊपर एक क्वेश्चन है. The question they have asked on the EEG. On the EEG, what I'm going to teach you how to see the EEG also, right? So here you will be having periodic sharp waves. Here you are going to have periodic sharp waves on the EEG. Okay, very good, right? So now for the treatment part, remember, there will be no treatment for this particular thing. Yes, kidsy, there will be no treatment. There will be no treatment for the Prine's disease, right? The next important disease, this one is also sporadic. Okay, this one is also sporadic. This is your Alzheimer. Alzheimer is a disease which is also sporadic. And in fact, it is one of the most important cause for dementia. What kind of a dementia it is? It is a subcortical or a cortical type of dementia. Remember, it is a cortical atrophy will be there. Cortical atrophy, cholinergic neurons will be decreased, cortical atrophy will be there. That would be leading to, it is a senile, it is a disease you will be finding in the senile patients, right? What about the genetic mutations? What are the genetic mutations that are associated with this particular disease? What is the gene? Genes are important for Alzheimer. Genes are important. They are asking question. So the gene is ApoE4 gene. ApoE4 gene is the gene which is going to be responsible here. Apart from that, we are having presenilin 1 and 2. Right? Here you will be having decrease in the levels of acetylcholine in nucleus of bacillus, in nucleus of Meernet bacillus. In the nucleus of Meernet bacillus, you will be having decrease in the levels of acetylcholine. Acetylcholine is responsible for increasing in the cognition. I've taught you in the pharma, right? It is going to increase the cognition of the patient. So cognition बढ़ेगा तो क्या होगा, उसको सब चीजें याद रहेगी. These patients are going to have what? Decrease in the acetylcholine. There will be cortical atrophy. There will be symptoms of dementia will be there, right? On histopathological examination, what you are going to find? Most common, you will be finding the senile neural plaques. Senile neural plaques. And these senile neural plaques are made up of what? They are made up of amyloid A beta. amyloid A beta chains, right? Then second question they are asking most characteristic. The most common we have seen, most characteristic thing will be tangles. What kind of tangles will be there? Try to answer. What kind of tangles? Neurofibrillary tangles will be there. Neurofibrillary tangles will be there, and they are going to have a protein that is going to be your tau protein. Tau protein, neurofibrillary tangles, tau protein, senile neural plaque, amyloid A beta. Okay, tangles से याद रख लो, tau protein. Tangles will be most characteristic, right? For the drug of choice, what is the drug would you like to give in this case? What is the drug of choice? These are going to be your donepezil, mementamine, yes, Hirano you will be finding in the Parkinsonism, right? Mementamine, and one more previous year question, one monoclonal antibody, that is going to be your aducanumab. This is your previous year question, important, right? Aducanumab is the monoclonal antibody that we can use here in the cases of Alzheimer. Okay, so it is going to be a sporadic disease, genetic mutation you have to remember, ApoE4, presenilin 1, presenilin 2, right? And you will be having on histopathology, most common will be senile neural plaques, amyloid beta, right? Neurofibrillary tangles with the tau protein, and drug of choice will be donepezil, mementamine, ribostigmine. These are the drugs we are using. Basically, we want to increase what? Acetylcholine. Basically, what we want to do, we want to increase the acetylcholine, right? Next question we are having in front of us. A 32-year-old female patient is presented to emergency with the episodes of bilateral visual loss. Now she is having vision loss. Okay, this happens when she runs. ये कब होता है vision loss? When she runs, she laugh, and she sneeze. She also stated that she is having a pulsatile type of headache. This particular patient is having some kind of a headache which generally does not fade away with the normal analgesics. ये analgesics से ठीक नहीं होता है, and this is a very important clue. CT scan of the brain shows no findings. There is no findings on the brain, right? On further examination, we found that this particular patient has raised ICP, intracranial pressure is high. Intracranial pressure is high, right? All of the following can be seen here except. So what is the diagnosis? The diagnosis they have given, always try to make the diagnosis in your hand. That is going to be intracranial pressure बढ़ गया, right? There will be raised intracranial pressure. Tell me, what is the normal intracranial pressure? Normal will be 10 to 20 mm of Hg. 10 to 20 mm of Hg. Raised कब बोलते हैं? When it is more than 25 mm of Hg. Okay, book के according, and it will be for the more than 5 minutes, right? Okay, 5 मिनट तक 25 mm Hg से ज़्यादा है, that is known as raised intracranial pressure. What is the triad that you will be seeing over here? Some of you are answering. You are answering for the last question or this one? This one. Okay, let me make you understand what is the triad. Try to understand what is the triad for what is the Cushing's triad? Cushing's triad. What is the Cushing's triad बेटा? Cushing's triad में तीन चीज़ें आती है. That is going to be HIB. That is going to be HIB. What is this H? This patient will be having hypertension. Hypertension is a part of Cushing triad. I4, there will be irregular breathing. Irregular breathing, मैंने पढ़ाया था फिजियो में. Irregular breathing pattern, chain strokes breathing pattern, increased ICP, right? Irregular breathing. Along with that, this patient is going to have bradycardia. This is a triad for Cushing's triad. Okay, this is known as Cushing's triad. Cushing's triad, right? So यहाँ पर तीनों चीज़ें हैं: hypertension, irregular breathing, bradycardia, right? Apart from that, this patient is having bilateral visual loss. Visual loss क्यों हो रहा है? Because of optic disc swelling. Optic disc swell हो रही है, इसकी वजह से vision loss हो रहा है. And whenever you find this particular word, remember Cushing triad के साथ में या एक दो फीचर भी है Cushing triad के, and you are finding this particular word, you will be thinking in the terms of increased intracranial pressure. Very important entity, right? Now What other things you will be finding? Let me give you other signs, because nowadays they are asking question on the basis of ICP, right? So what other things you can have? You can have headache, you can have projectile vomiting. The patient can have projectile vomiting. Because of increase in the pressure, patient can also have altered sensorium. Okay, they can also have involvement of cranial nerve, which is the cranial nerve that is most commonly involved. That is going to be sixth nerve, right? Apart from that, this optic disc, right? We can have papilledema. Very, very characteristic. If you find this word, directly jump for the diagnosis, right? Apart from that, we can have some bad signs. What are these bad signs we are having? Upper motor neuron signs we can have. We can have posturing. Two types of posturing I've taught you: decorticate posturing, decerebrate posturing, right? Decorticate rigidity, cerebrate rigidity. So you can also have posturing, right? You can have upper motor neuron signs. These are going to be exaggerated deep tendon reflex, and you will be having Babinski positive. Okay, all these things are going to go in the diagnosis of it raised intracranial pressure. So to raise, if the intracranial pressure is more, what you need to do, you just need to decrease the pressure. Okay, but before that you need to check for the GCS. Remember GCS. Also please see GCS from your surgery, right? Please see GCS from your surgery notes. Definitely they will be asking question on GCS. I have not incorporated, but if the level, if the number is less, if the number is around 8, what you need to do, you will be doing intubation. You will be intubating that particular patient first, then you will be going for the management of ICP. What are the things you will be doing? You can do two things, very, very important. First thing, you can take some general things. What are the general things? First thing you can do, pressure बढ़ा हुआ है brain के अंदर. What you will be doing? First thing you will be doing head elevation. सबसे पहले क्या कर दोगे? Head elevation कर दोगे, right? Or you can remember the position. That is going to be, the patient should be in the reverse Trendelenburg position. Second thing, you will be doing the symptomatic treatment. अगर patient को fever है, you will be giving painkillers to the patient. Patient को pain है, fever है, okay? But you should be remembering, you should not give, it is clearly mentioned in the Harrison, you should not give any obnoxious stimuli. ऐसा नहीं है बार बार सैंपल ले रहे हो, बार बार सैंपल निकाल रहे हो, ओके? सो अवॉइड सक्शन, अवॉइड सैम्पलिंग, ओके? बार बार सैम्पलिंग नहीं करना, बार बार सक्शन नहीं करना, एलपी नहीं करना, राइट? सो दीज आर द थिंग्स यू शुड नॉट डू, राइट? देन व्हाट यू नीड टू डू, then you will be going for the osmotherapy. What are the things we are going to use for decrease in the pressure? We can use things like IV mannitol, very, very important, IV mannitol. We can also use IV acetazolamide. और क्या दे दोगे? एसिटाजोलामाइड. अगर किडनी प्रॉब्लम है तो मैनिटोल नहीं देना है, राइट? अगर बीपी कम है, यू कैन इंक्रीज द बीपी बाय वैसोप्रेसर्स. वैसोप्रेसर्स क्या होते हैं बेटा? Vasopressors. Give me some example of a vasopressor, right? So why we are giving? Just to increase the mean arterial pressure, so that cerebral perfusion would be good. Brain तक blood जाना चाहिए, good cerebral perfusion should be there, right? So we can increase the mean arterial pressure in the cases of shock, patient, right? And lastly, we can intubate our patient, and we can increase the respiratory rate of the patient. Respiratory rate बढ़ाने से क्या होगा? There will be CO2 washout. Whenever you are hyperventilating, you study about mountain sickness, you go to mountain, what you will be doing? You are hyperventilating, you are throwing out the excess CO2. Remember, CO2 and H plus are brothers, right? CO2 and H plus are brothers. So whenever you are having excess of CO2, that means you are having excess of acid. Excess of H plus. Excess of H plus means there will be acidosis, respiratory acidosis. In the cases of diabetic ketoacidosis, you will be having what? Acidosis. So what you are doing? You are hyperventilating. And what do we call it? DKA, hyperventilation. What do we call it? What breathing pattern we call it? Right? So same thing will be happening here. We are increasing the respiratory rate so that CO2 washout will be there. CO2 washout will be there. Apart from that, whenever CO2 is going away, what is going to happen? You will be having decrease in the CSF production. So CSF का production कम हो जाएगा तो क्या brain के अंदर pressure कम होगा? हाँ sir, pressure कम होगा. That is what we want, right? Apart from that, if all these things are not working, we can induce the coma in the patient. This is a very very important thing. If nothing is working, तो हम लोग पेशेंट को क्या करते हैं? कोमा में डाल देते हैं. हाउ वी कैन इंड्यूस द कोमा? विद द हेल्प ऑफ phenobarbital. Okay, we can also do hypothermia in the patient. Therapeutic hypothermia. यहाँ पर टेम्परेचर 37 से 33 डिग्री सेल्सियस तक ले जाएंगे, राइट? दैट इज गोइंग टू बी योर थेरापेटिक हाइपोथर्मिया. दिस इज हाउ वी आर गोइंग टू ट्रीट द पेशेंट ऑफ ICP, right? So what is not going to be there? Remember, hypotension is not going to be there, right? So hypotension is going to be the odd one out. Bradycardia will be there in the HIB. Bradycardia will be there. Chain stroke breathing is the irregular breathing pattern that we are having. Decorticate posturing that can be happened, right? Decorticate, decerebrate positioning can be there. अगर GCS कम है 8 से, एक बार समरी दे देता हूँ. व्हाट इज द समरी? व्हेनेवर समवन इज हैविंग रेज्ड इंट्राक्रैनियल प्रेशर, हाइपरटेंशन है, इरेगुलर ब्रीदिंग है, ब्रेडिकार्डिया है, ऑप्टिक डिस्क में स्वेलिंग हो रखी है, दिख नहीं रहा है, व्हाट यू नीड टू डू? यू नीड टू टेक द पेशेंट टू द हॉस्पिटल, राइट? अगर GCS 8 से कम है, वी विल इंट्यूबेट द पेशेंट. अगर GCS 8 से कम नहीं है, फर्स्ट ऑफ ऑल यू विल एलिवेट द हेड ऑफ द पेशेंट. यू विल बी अवॉइडिंग एनी काइंड ऑफ सक्शन. कुछ भी इंसर्ट नहीं करना, पेन नहीं देना पेशेंट को. देन you will be going for osmotherapy to try to decrease the pressure in the brain. You can also use vasopressor in the cases of shock. अगर patient shock में, you can give vasopressors. Okay, you can intubate your patient, increase respiratory rate. Nothing is working, you can induce the coma, phenobarbital coma, right? You can induce the coma in the patient. You can do therapeutic hypothermia in the patient, right? Now the next question we are having, the last question from the CNS. Right, an infant is presented to the OPD by her mother. She stated that the baby is doing some kind of abnormal movements. Right? Like flexion of the neck. There will be flexion of the neck along with the flexion of the limbs, like that. Okay, and also there is a developmental delay. Right? Doctor prescribed an EEG. And EEG shows hips arrhythmic pattern. Okay, what can be the most likely this patient is suffering from? What does this patient is suffering from? What kind of EEG pattern can you appreciate over here? This type of pattern जहाँ पर ऐसे बहुत सारा उल्टा सीधा कुछ बन रहा है. Okay, this is known as hips arrhythmia. This is known as what? Hips arrhythmia, also known as chaotic rhythm. This is hips arrhythmia, chaotic rhythm, seen in the cases of infantile spasm. Infantile, West, both are different thing, right? So this is seen in the cases of infantile spasm. Also known as, this is also known as what? Salam seizure. This is also known as Salam seizure. Infantile spasm, Salam seizure, hips arrhythmia, right? Now, what can be the answer? Is it West syndrome? Is it absence seizure, tuberous sclerosis, status epilepticus? Let me make you understand first what is epilepsy. So what is a tremor? What is a seizure? What is a convulsion? First of all, let me make you understand the basics. What are the basics? Tremor means there will be abnormals. Tremor means abnormal skeletal muscle contraction is known as what? If there is abnormal contraction of skeletal muscle, this is known as tremors. On the other hand, palpitation will be what? Palpitation matlab there will be abnormal cardiac muscle movements. बहुत ज़्यादा हार्ट कॉन्ट्रैक्ट कर रहा है, दैट इज नॉन एज मसल मूवमेंट्स, दैट इज नॉन एज पाल्पिटेशन. सीजर में क्या होगा, देर विल बी sudden uncontrolled electric discharge, sudden uncontrolled electrical discharge from the brain, and remember here you will be having a cause present. Always remember there will be a cause present. This is known as seizures. What happens in convulsion? There will be motor movements following the seizure. Here you will be having muscle contractions due to seizures, like you studied about preeclampsia, eclampsia. तो सीजर मतलब क्या हो गया, ब्रेन में abnormal impulse जनरेट हो रहा है, दैट इज सीजर, राइट. अगर उसकी वजह से बॉडी में मूवमेंट आ रहा है, दैट इज नॉन एज कन्वर्शन. व्हाट इज एपिलेप्सी? मोर देन टू सीजर्स or 2 episodes of seizures, but it should be unprovoked and far apart from 24 hours. मतलब 2 या 2 से बार ज़्यादा बार अगर सीजर आता है without any cause, unprovoked, that is known as what? That is going to be in the favor of diagnosis of epilepsy. मायोक्लोनिक का मतलब क्या होता है? मायोक्लोनिक मतलब sudden involuntary muscle movement, sudden involuntary muscle jerks is known as myoclonus. Clonic means there will be rhythmic with a rhythmic and repeated contraction. There will be rhythmic and repeated contraction and relaxation is known as what? Clonic seizures. Okay. Atonic में क्या होगा? टोन चला जाएगा, sudden loss of tone. खड़ा है बंदा, sudden loss of tone हो गया, what will happen? बंदा गिर जाएगा, that is going to be atonic seizure. Tonic में क्या होगा? Sudden stiffening of muscles will be there. That is going to be your tonic seizure. That is going to be your tonic. GTCS is also known as grand mal epilepsy. देखो इसकी EEG फाइंडिंग पूछते हैं. ग्रैंड माल एपिलेप्सी की EEG फाइंडिंग में क्या मिलेगा? सम EEG फाइंडिंग यू हैव टू रिमेंबर. कुछ ही है, ज़्यादा याद नहीं रखनी, कुछ याद रखनी है. what are the important ones? I am going to make you write. Okay, so you will be having spikes in all 20 leads. So GTCS में generalized tonic clonic seizure, you will be having grand mal epilepsy, you will be having spikes in all the 20 leads. Okay, और क्या important बात है इसमें? Here you will be having post ictal deficit. Seizure के बाद में there will be neurological deficit will be present. Okay, treatment के लिए क्या दोगे? Drug of choice will be valproate. Okay, in the cases of absent seizure is also known as petit मतलब छोटा, petit mal epilepsy. इसके ऊपर 2-3 बार क्वेश्चन आया अभी रिसेंट एग्जाम में. EEG वेव्स के अंदर क्या मिलेगा? फर्स्ट यू नीड टू अंडरस्टैंड, 2 तरीके का होता है. पहला होता है टिपिकल, सेकेंड होता है एटिपिकल. सो इन टिपिकल एब्सेंट सीजर यू विल बी हैविंग 3 हर्ट्ज स्पाइक and slow wave. 3 hertz spike and slow waves pattern will be there. Whereas in the cases of atypical, कुछ बुक्स में ये 4 से 6 भी लिखा हुआ है, राइट, बट यू कैन सिंपली रिमेंबर 3 वेव्स, राइट. अगर एटिपिकल की बात करेंगे, इट विल बी लेस देन 2.5 हर्ट्ज स्पाइक एंड स्लो वेव पैटर्न विल बी देयर. अगर लेस देन 2.5 है, दैट इज गोइंग टू बी इन द फेवर ऑफ एटिपिकल एब्सेंट सीजर. ओके, एंड इफ इट इज मोर देन 3, if it is 3, that is going to be in the favor of typical seizure. Drug of choice is going to be, we are going to use valproate, we are going to use ethosuximide. देखो क्वेश्चन में एक ही ऑप्शन आता है. जनरली क्लिनिकल प्रैक्टिस में हम लोग वाल्प्रोइड यूज में लेते हैं. क्वेश्चन में एक ही ऑप्शन आता है, एक ही ऑप्शन में, बट यू कैन रिमेंबर अगर 4 साल से ऊपर है वी कैन रिमेंबर वाल्प्रोइड, अगर 4 साल से नीचे देन वी कैन रिमेंबर ethosuximide. It is a bit controversial topic, I don't want to fall in that. Okay, next thing, most common in children. What is just follow here, main notes, whatever you are having, just follow that. Okay, what is the most common cause in children? What is the most common type of epilepsy in children? Most common type of epilepsy in children, that is going to be your benign Rolandic epilepsy. And what you are going to find over here, you are going to have centrotemporal biphasic sharp waves. Here you are going to have centrotemporal biphasic sharp waves, right? This is going to be most common type of epilepsy in children. In adolescent, the most common epilepsy is juvenile myoclonic epilepsy. Juvenile myoclonic epilepsy, here you will be having 4 to 6 hertz polyspike pattern. 4 to 6 hertz polyspike pattern will be there. 4 to 6 hertz polyspike pattern will be there, right? Now, in the cases of infantile spasm that we have seen, in the cases of infantile spasm or Salam seizure, you will be having specific pattern that is known as hips arrhythmia. Now, I hope you understand what is hips arrhythmia. And the drug of choice for infantile spasm is going to be ACTH. ACTH. But if they have written you, if they write you hips arrhythmia, listen to me carefully. Hips arrhythmia is written along with infantile spasm, along with developmental delay, then this is known as what? Then this is known as West syndrome. Then this is known as West syndrome. Then this is known as West syndrome, right? If infantile spasm plus, in the question they will write you one more question they have asked in NEET PG, they can repeat. If they have given you question like infantile spasm along with ash leaf macules along with Conan tumors or periungual fibromas will be there, right? Along with the developmental delay, this is going to be in the favor of tuberous sclerosis. This is all going to be in the favor of tuberous sclerosis. Okay, and what is the drug of choice for tuberous sclerosis? That is going to be your vigabatrin. So if they ask you what about infantile spasm, you will be answering as ACTH. If they ask you about hips arrhythmia plus developmental delay, that is going to be your West syndrome. Hips arrhythmia, infantile spasm, ash leaf macules will be there, some body involvement will be there, some kind of macules is a flat lesion, there will be there. Okay, Conans, that will be periungual fibromas will be there. That is going to be in the favor of tuberous sclerosis, and the drug of choice will be vigabatrin. Okay, and here you will be having some visual field defects, right? The next we are having is focal seizure और पार्शियल सीजर. नाउ वी अंडरस्टैंड फोकल मतलब कोई ना कोई एक जगह से इम्पल्स जनरेट हो रही है. पार्शियली मीन्स इट इज हाफ ऑफ द ब्रेन. दैट इज गोइंग टू बी पार्शियल सीजर. द ड्रग ऑफ चॉइस विल बी carbamazepine. The drug of choice will be carbamazepine. And for status epilepticus, the drug of choice will be here. What is status epilepticus? Here you will be having seizure more than 30 minutes. What is status epilepticus? If the seizure is remaining more than 30 minutes, they have asked you question, what is the drug of choice you would like to give in this particular case? यहाँ पर क्या दोगे? First you will be using IV lorazepam. But IV lorazepam injection एक single injection देना है. If it is not going to be effective, what you will be doing? You can use IV midazolam. Midazolam का infusion start कर देना है. Okay, yes, carbamazepine, or we can also use oxcarbamazepine, right? Epilepsy in pregnancy, we can use lamotrigine. But one more safer drug we are having better than lamotrigine, that is going to be your levetiracetam, right? For febrile seizure, the drug of choice will be rectal diazepam. We can also give oral. We can also use rectal diazepam. This is going to be the most common thing in the children. after fever there will be seizure, right? Subtle seizure you will be finding in the neonates. It is going to be newborn. It is going to be in the newborn. And what is the drug you would like to use in the subtle seizure? That is going to be your phenobarbital in the newborns. In the cases of newborn you will be using what? Phenobarbital, the subtle seizure, right? So this is pretty much that you need to remember about the CNS. I hope you will be able to solve most of the question from this, right? So we have seen about the ICP, we have seen about the multiple things, right? Just give me a moment, I will just charge the pencil, or let me start. Okay, so the next question that we are having in front of us, just try to see. A 26-year-old male patient is presented to emergency with the complaints of symptoms like dark urine. The patient is having dark urine. We are going to start it off with the GIT now. Okay, patient is having fever, patient is having jaundice, nausea, vomiting, fatigue, and on further examination, serological examination, we have found that the patient is positive for, first thing, that is going to be your HbSAg. HbSAg positivity is there. Second thing, this patient is positive for IgM type of anti-HBC, okay, anti-HBC IgM type of antibody, and this patient is also positive for HBeAg, okay, HBeAg. So is it going to be what kind of diagnosis? Is it a acute? Is it a chronic? Is it a chronic infective hepatitis? Is it a acute infective hepatitis B? Very good, I'm getting the right answers. You all will pass, definitely. My best wishes. Okay, look here. HbSAg is going to be the first antigen. Those who don't know how to solve this question, just understand these three words and you are able to solve the question. Okay, so first HbSAg, that is the antigen, surface antigen, right? It is the first antigen that is going to be present in the body. ये पहला antigen होगा, right? The first antibody that is going to formed is going to be your एंटी HbC IgM टाइप ऑफ एंटीबॉडी. अगर ये IgM की जगह IgG दिया होता, दैट इज गोइंग टू शो यू अबाउट द chronic thing. Okay, ये तो पता होगा. IgM is going to be responsible for the acute thing, whereas IgG is going to be responsible for the chronic thing. And this HbEEg is going to be responsible for the replication. ये क्या बताती है कि वायरस डिवाइड हो रहा है. ये क्या बताता है? रेप्लिकेशन, इन्फेक्टिविटी. इट इज रेस्पॉन्सिबल फॉर द इन्फेक्टिविटी, राइट? ये समझ में आ गया? राइट? सो लेट्स ट्राई टू अंडरस्टैंड द थिंग्स हियर, राइट? द फर्स्ट वन वी आर हैविंग इज HbSAg पॉजिटिव है. ओके, let me bring all these things for you so that you are able to understand this. ये तीन चीज़ें याद कर लो. You will be able to solve. Okay, look here. तो यहाँ पर क्या है? फर्स्ट थिंग, एंटीजन प्रेजेंट है नहीं है? HbSAg is present, right? So this is going to be first antigen. Second thing, IgM type of antibody is there. IgM antibody present है, मतलब क्या है? ये acute infection है. IgG अगर present है, it is going to be your chronic infection. Right? So which is the first antibody that is going to come? That is going to be your anti-HbC antibody. So we are having this IgM, मतलब क्या है? Infection कैसा है? Acute है. Third thing, this HbEEg is positive. That means it is showing the infectivity, right? So what kind of hepatitis B it is? It is positive, right? It is a acute hepatitis B with high infectivity, right? So this is going to be the first thing. Okay, this is going to be the first thing. Second thing is going to be, this is going to be the second thing. Here we are having anti-HbSAg positive. Here we are having IgG positive. IgG मतलब क्या हो गया? Is it a acute infection or is it a chronic infection? So this is going to be in the favor of chronic hepatitis. anti-HbE पॉजिटिव है. HbE पॉजिटिव है मतलब क्या हो गया? ये इन्फेक्टिविटी भी यहाँ पर ज़्यादा है, राइट? सो दिस इज गोइंग टू बी अ क्रॉनिक हेपेटाइटिस विद वायरल रेप्लिकेशन. दैट मीन्स विद हाई इन्फेक्टिविटी अगेन. okay, with high infectivity again, right? I hope you understand. This is how these tables are written, right? All these things will be same, right? For example, let's look here. यहाँ पर एंटी एच बी एस एंटीबॉडी प्रेजेंट है, एंटी एच बी एस एंटीबॉडी प्रेजेंट है, मतलब क्या हो गया, दिस इज अ वैक्सीनेटेड इंडिविजुअल, दिस इज अ वैक्सीनेटेड इंडिविजुअल, राइट? दिस इज अ वैक्सीनेटेड इंडिविजुअल। बाकी सब क्या है, नेगेटिव है, ऑल ऑफ अदर थिंग्स विल बी नेगेटिव। अगर यहाँ पर एच बी एस ए जी पॉजिटिव है, दैट मीन्स इन्फेक्शन इज प्रेजेंट, ओके। ये भी पॉजिटिव है, एंटी एच बी एस, दैट मीन्स इन्फेक्शन, आई थिंक इन्फेक्शन वुड बी विद द अदर थिंग ऑल्सो, राइट? दो सीरोटाइप अलग अलग भी हो सकते हैं, राइट? देन वी आर हैविंग आईजीजी एंटीबॉडी। आईजीजी मतलब क्या हो गया, इट इज गोइंग टू शो अस द क्रॉनिक इन्फेक्शन। ये प्लस माइनस भी हो सकता है, ये भी प्लस माइनस हो सकता है, राइट? दिस इज गोइंग टू बी योर क्रॉनिक हेपेटाइटिस बी विद हेट्रोटाइपिक एंटी एच बी एस, राइट? अलग तरीके की एंटीबॉडी है यहाँ पर। दिस इज योर आईजीएम पॉजिटिविटी। यहाँ पर देखो एच बी एस पॉजिटिव नहीं है, एच बी एस पॉजिटिव नहीं है मतलब क्या, डिजीज नहीं है? नहीं, ऐसा नहीं है, डिजीज है, बिकॉज दिस इज योर IgM antibody which is going to be present over here. This is your window period. यहाँ पर क्या है, एंटीजन छुपा हुआ है अभी, ओके? एंटीबॉडीज बनना स्टार्ट हो चुकी है, फर्स्ट एंटीबॉडी, बट एंटीजन अभी छुपा हुआ है, यहाँ पर कोई एंटीबॉडी सरफेस के अगेंस्ट नहीं है। सो दिस इज गोइंग टू बी अ विंडो पीरियड, ओके? सो दिस इज हाउ वी आर गोइंग टू assess it, okay? एक बार देखना, if you are having any difficulties you can always ask me, right? So answer here in this particular case will be, यहाँ पर एंटीजन प्रेजेंट है, so the disease will be present। IgM मतलब ये कैसा हो गया, अक्यूट हो गया। एंटी एच बी सी प्रेजेंट है मतलब क्या हो गया, ये इन्फेक्शन तो हो ही गया, राइट? एंड दिस वन इज गोइंग टू बी एंटी एच बी ई इजी प्रेजेंट, मतलब ये हाईली इन्फेक्टिव हेपेटाइटिस बी है, दैट इज गोइंग टू बी द थिंग, right? We can use the lead drug, okay, lamivudine, efavirenz, tenofovir. These are the drugs we can use in the cases of hepatitis, right? Next question we are having is, a 24-year-old patient is presented to the OPD with the symptoms of, patient is having what, anorexia is there, patient is having vomiting, patient is having weight loss, jaundice is there, stiffness in the muscle is there, right? Along with the tremors, and a golden brown color ring, and a golden brown color ring is seen on the iris. So what is this golden brown color ring seen on the iris? Have you heard about this term, right? And this can be associated with what? Try to answer this one. Is it a Dubin-Johnson syndrome? Is it a hemochromatosis? Is it a Rotor syndrome or your Wilson disease? So this is going to be iris, and this is going to be your KF ring. This is your Fisher ring. These are the other symptoms that you have to remember about the Wilson disease. There will be stiffness in the muscle, there can be tremors, there can be golden brown color ring that on the descemet membrane, okay? So there will be copper deposits on the descemet membrane, copper deposits on the descemet membrane. This is known as what? This is known as KF ring, okay? And this KF ring is very highly suggestive of a disease that is known as Wilson's disease. Wilson's disease. And what is the inheritance? What is the inheritance you will be having here? Is it autosomal dominant or autosomal recessive? Remember, it is a autosomal recessive disease, and you will be having genetic mutation that will be your ATP7B gene. ATP7A कौन सी disease में होता है, right? ATP7B gene on 13q chromosome, important, also remember this, okay? NI set में question था, they have given ATP7B but along with the arm also, right? So chromosome number भी याद रखना है, right? So it is a autosomal recessive disease with ATP7B on 13q chromosome, right? This is also known as hepatolenticular degeneration. Hepatolenticular degeneration, okay? Hepatolenticular degeneration, right? What other things you need to remember about the course of the disease? First of all, it is going to damage the hepato, means liver. First it is going to damage the liver, then it is going to damage your eyes. In eyes you will be having that KF ring, and apart from the ring you can also have a cataract that is known as sunflower cataract. And after the involvement of eye, it will be going to the brain. In which part of the brain? They have asked you, in the basal ganglia. In the basal ganglia. right, in the basal ganglia, and that is going to produce the symptoms of Parkinsonism and some psychiatric diseases also. Psychiatric symptoms will be there. Psychiatric symptoms will also be there. The symptoms of Parkinsonism will come and psychiatric symptoms will also be there. Next question they have asked you is about the screening. About the screening बेटा क्या स्क्रीन करोगे विल्सन डिजीज के लिए? यू विल बी चेकिंग फॉर द सीरम सेरुलोप्लाज्मिन. तो सीरम सेरुलोप्लाज्मिन क्या हो जाएगा? सेरुलोप्लाज्मिन इज द कॉपर ट्रांसपोर्टर. इट विल बी decreased. Transferrin is the transporter of what? Try to answer, right? You will be having urine. You can check for urine copper excretion. So अब क्या होगा? इसको ट्रांसपोर्टर तो है नहीं, तो what will happen? This one will be going out from the urine, right? So copper will be going out from the urine. Okay. On MRI, you will be finding a specific sign. Someone has already answered, right? That is known as giant face of panda. Giant face of panda sign. Giant face of panda sign will be there. Okay. One more question. What is the investigation of choice, beta? What is the investigation of choice here? Yes, investigation of choice and will in this particular disease will be liver biopsy. First involvement is what? Liver. So याद रखो यहाँ पर क्या रखना है याद? Liver biopsy we are going to do for the investigation of choice, right? For management, for the treatment, you can use copper chelators. You can use copper chelators like trientine. याद रखना है treatment. Trientine, D-penicillamine. These are the copper chelators. One more thing you can also use for the maintenance that will decrease the copper reabsorption. That is going to be your you can remember, for maintenance you can use zinc acetate. You can use zinc acetate for the maintenance. You can use zinc acetate for the maintenance. Molybdate, yes, molybdate we can also use for neurological features, beta. Okay, molybdate we can also use, Rahul, you can remember. Desferoxamine nahi, we can use drug for neurological features. For neurological features, the drug that we are using is tetrathiomolybdate. Molybdate. The drug that we are using is tetrathiomolybdate. ठीक है? Okay. So this is going to be the short story about the Wilson's. ATP7A की वजह से क्या हुआ था? That is going to be your Menkes disease. 7B is going to cause what? Wilson's disease. It is going to be autosomal recessive condition, right? You will be having excessive copper deposition in the descemet membrane leading to formation of KF rings. You will be having hepatolenticular degeneration, right? Serum ceruloplasmin कम हो जाएगा और excretion बढ़ जाएगा. What is the sign that you will be having on the MRI? That would be your giant face of panda sign. Dawson finger कहाँ देखा था? Where do you see the Dawson finger? Try to answer, right? And these are the management that we are having, right? Apart from this particular thing, now we are having what? We are done with this. Now we will be discussing about the Rotor and Dubin-Johnson. Okay, now we will be discussing about the hyperbilirubinemia, right? So let me make a table for it. So you are having hyperbilirubinemia. एक short table बनाते हैं इसके बारे में, right? We are having two things. One is your conjugated disorder. One is your unconjugated disorders, right? So unconjugated में क्या आता है? Unconjugated bilirubin, you will be having two things. One is going to be your Crigler-Najjar. First is going to be your Crigler-Najjar syndrome. What is going to happen? UDP, you will be having decrement in the glucuronil transferase. UDP glucuronil transferase में कमी हो जाएगी, right? अगर ये नहीं होगा तो क्या conjugation होगा नहीं होगा. You will be having unconjugated bilirubin. You will be having unconjugated bilirubin. In fact, this is also of two types. One is going to be your type 1, second is going to be your type 2. 1 में क्या होगा? The patient will die. Okay, बच्चा मर ही जाता है. Type 2, what is going to happen? These are the newborns. ये compatible होते हैं, but you need to give the drug. What is the drug we are going to give here? What is the drug we are going to give here? That is going to be your phenobarbital. Phenobarbital. Right? Yes. Next, we are having is going to be your Gilbert syndrome. Crigler-Najjar or Gilbert syndrome. Here you will be having what? Here you will be having decrease in the production of the same enzyme. So it will be having a mild disease. It will be having a mild variant of the disease, Gilbert syndrome. Okay, so these are the two important things. Now we are having conjugated में दो चीजें याद रखनी है. Doctors are always conjugated, so you can remember D and R. First is your Dubin-Johnson. Dubin-Johnson syndrome. Okay, where is the problem in Dubin-Johnson syndrome? There will be problem with the transfer of conjugated bilirubin to कहाँ जाना चाहिए? बिलियरी कैनलकुलाई. तो यहाँ पर ट्रांसफ़र में दिक्कत आ जाती है, और अगर ट्रांसफ़र में दिक्कत आ गई तो इट विल बी गेटिंग एक्यूमुलेटेड एंड इट विल बी गिविंग सम कलर. सो हियर यू विल बी हैविंग पिगमेंटेड लिवर. Here you will be having pigmented liver. Okay, DRR conjugated Dubin-Johnson. Second one is your rotor. Okay, यहाँ पर antibodies याद रखनी है. What are the antibodies? Very good, Shubham. That is going to be your MRP2 antibody, and one more you can remember, that is going to be your ABCC2. These are the two important things that you have to remember. These are not antibody, these are basically the genes, right? These are the genes, MRP2 and ABCC2. You will be having pigmented liver. Here the conjugated bilirubin will get accumulated and it will not be able to pass through biliary canaliculi, right? And in the rotor syndrome, here you can simply differentiate in the conjugated. Here the liver will be normal, beta. Here the liver will be normal. There will be no discoloration. Here the color will be normal. Here OATP, here there will be problem with the OATP B1 or B3 deficiency will be there. OATP B1 or B3 deficiency will be there. Okay, Shubham, right? So that is going to be the rotor. This is the small table for the Dubin-Johnson and hemochromatosis. Last thing we are having is hemochromatosis. Just make a note over here, right? This is going to be because of HFE gene mutation. I have explained all the complete iron metabolism in the physiology. You can watch that, right? So what is going to happen? HFE gene mutation is going to be there. HFE gene mutation will be there on 6p chromosome, and what is going to happen? You will be having increase in the आयरन ओवरलोड. हेप्सिडिन में दिक्कत आ जाएगी, आयरन ओवरलोड बढ़ जाएगा, right? You will be having excessive deposition of iron onto the liver, onto the different organs, right? So when this iron is going to get deposited on the liver, you will be having liver disease, right? You will be having chronic liver disease. When it is going to go to your pancreas, it can produce Brown's diabetes. It can even get deposited in your joints and it can lead to formation of arthritis, right? So excessive iron will be deposited in the body. Iron absorption कहाँ से होता है? Absorption of iron is taking place at the level of what? Try to answer. Iron absorption. Yes, it will be getting deposited on the skin. You will be having bronze skin. Basically there will be iron. जो भी हम iron खाते हैं, iron will be going into your stomach, then in your duodenum. From duodenum it will be going to the blood, right? It will be going to the blood, right? Very very important, iron metabolism. Definitely they will ask question, right? तो जो भी iron खाया है, it will be converting first whatever iron we are eating, it is in the Fe3 plus, then it will be converting into Fe2 plus. Now it will be going inside with the divalent metal transport, DMT, right? And now it can either stored in the form of ferritin, or it can even go out from the ferroportin, right? Ferroportin, it can even go out from the ferroportin. And now this iron which is coming out from the ferroportin, it will be taken up through the blood. Transferrin क्या करेगा, आयरन ट्रांसपोर्टर है वो, उसको कम उठा लेगा, एंड देन इट विल बी ट्रांसपोर्टिंग टू द लिवर, इट विल बी ट्रांसपोर्टिंग टू द बोन मेरो फॉर द प्रोडक्शन ऑफ आरबीसीज. अब जब ये ज़्यादा आयरन निकल के ट्रांसपोर्ट होने लग जाए, दैट इज व्हाट इज नोन एज hemochromatosis. And whenever this iron is going to deposit on the liver, you will be having scarring of the liver, chronic liver disease. When it is going into your pancreas, you will be having what, Bronze diabetes. It is going to affect your skin, right? Basically iron deposition is going to affect, right? Now what you can do for the treatment, you can do what, कैसे इसको कम करोगे? You can chelate the iron. Apart from that, you can also do what, phlebotomy. You can also do phlebotomy, or some iron chelators. You already know these are going to be your deferriperon, desferoxamine. These are going to be the drugs you can use, right? So that is going to be the treatment for hemochromatosis, right? I hope all of these terms are clear to you now. Okay, the next question. The next question is about the scores. Definitely you will be having a question on the scores in your exam. So we are having different scores, we will be discussing about that, right? So the first one important we are going to have is going to be your MELD score. So a 57-year-old male patient is diagnosed with the liver cirrhosis. Patient is having what, liver cirrhosis, and is being assessed on which score? This patient is being assessed on MELD score. For the prognosis and mortality, this is the score we are going to use for prognosis and mortality, right? And the score comes out to be 28. scores कितना आया, 28 आया. And recommended for liver transplant. Patient को बोला डॉक्टर ने कि जाओ liver transplant करना है, right? All of the following are the component of MELD score except. So what is the mnemonic? Everyone, exam is so near, guys. The mnemonic is, this is your model for end stage liver disease. This is your model for end stage liver disease. This is your end stage liver disease, right? अगर स्कोर आता है आपका मोर देन 17 से ज़्यादा अगर स्कोर है, रिमेंबर इट इज़ अ इंडिकेशन फॉर लिवर ट्रांसप्लांट. इट इज़ अ इंडिकेशन फॉर लिवर ट्रांसप्लांट. Score more than 17 is indication for liver transplant, right? What are the components, beta? What are the components of this MELD score? Simple mnemonic याद रखो, CBI. Yes, CBI. What are the three things? We are having serum creatinine. We are having serum creatinine. We are having B for bilirubin will be there. And we are having I for INR. Right, we are having I for INR, right? So which one is not the component of this particular MELD score? That is going to be your albumin is not the component. So the answer in this particular case will be albumin. Okay, now tell me about the PELD score, beta. What is PELD score? PELD score. PELD. Let's discuss about all the important scores here itself. So we are having MELD score, then we are having PELD score. This is used for the children's, right? This is used for the children's under 12 years. Under 12 years children. Under 12-year children for liver transplant. The score that we are using is going to be your PELD score. Pediatric score, right? End stage liver disease. What are the components? What are the components? So you can remember big A, बड़ा वाला A. Okay, ये बड़ा क्यों हो गया? Because it is having 2 double A. It is having 2 double A, right? So B4, there will be bilirubin. There will be bilirubin. I4, there will be INR. There will be INR. G4, there will be assessment of growth failure. There will be assessment of growth failure. Any double A, first A is responsible for the albumin levels and second A is responsible for the age of the person, right? So that is going to be the PELD. Yes, it is not in the PELD. Creatinine is not in the PELD, right? So this is going to be the PELD score. Then we are having CPS, child pug score, or CPS, child pug score. So what is the mnemonic for that? It is going to be your beta. It is going to be your beta. Okay beta, देखो. So what are the things we will be having here? We will be having, as for serum, bilirubin will be there. E for encephalopathy. Encephalopathy is a component, right? T for PT. You have to remember this one, PT. T याद रखना पड़ेगा बस, ठीक है? Bilirubin is there. Simply you can remember bilirubin, right? A for ascites is a component, and A for albumin is also a component, right? So that is going to be your child pug score. Yes, anything you can remember. Educated Bab, yes, that is also true, right? So whatever you want to remember, बेटे के साथ में बाप भी याद कर लो, ठीक है? बाप कहाँ पर होता है? What is the mnemonic we are using? बाप कहाँ यूज में लेते हैं? That is your nasal prognostic index. बेटा पढ़ लिया तो बाप को भी पढ़ो. That is going to be your Nazar's prognostic index used for which disease? अभी अभी देखा था एक disease. That is going to be your nothing but your Wilson disease. Wilson disease में यूज में लेंगे, right? So the mnemonic is BAP, BAP. And what are the three things we are having? B for bilirubin will be there, A for AST, and P for PTINR, right? So this is going to be the Nazar's prognostic index. Right? This one is going to be the Nazar's prognostic index, right? So it's calculate what to calculate. At least you should be remembering this particular set of information. इतना तो पता होना चाहिए, right? So we are having the MELD. Just revise with me here itself. We are having MELD. MELD का mnemonic क्या है? CBI. The mnemonic is CBI. C for creatinine, B for bilirubin. Speak with me. I for INR. Right? Second, we have studied about the PELD score. We are having component that is going to be big A. A will be having double A, right? So we are having bilirubin, we are having INR, we are having growth failure, and double A will be albumin and age will be there, right? Child pug score, that is going to be your beta. B for bilirubin, E for encephalopathy. Why this encephalopathy is happening? Anyone can answer, right? T for PTINR will be there, A for ascites, and A for albumin will be there, right? And Nazar prognostic index will be responsible for the BAP, that is going to be BAP, bilirubin, AST, and PT, right? This encephalopathy is happening because the ammonia is going to get converted into urea in the liver. Now the liver is not working. अगर liver ही काम नहीं कर रहा तो क्या ये अमोनिया यूरिया में कन्वर्ट होगा? नहीं होगा. तो ये अमोनिया कहाँ जाएगा? ये ब्रेन में जाएगा और जाके इन्फ्लामेशन कॉज करेगा. दैट इज व्हाट इज नॉन एज एनसेफेलोपैथी. ओके, उसको एनसेफेलोपैथी वाले सिम्टम्स आएंगे. दैट इज गोइंग टू बी द एनसेफेलोपैथी. एंड व्हाई दिस थिंग इज हैपनिंग? आई हैव टोल्ड यू अबाउट एल्बुमिन. द फंक्शन ऑफ एल्बुमिन इज टू मेंटेन BCOP, ब्लड कोलोइडल ऑन्कोटिक प्रेशर मेंटेन करना है. सिंपल अंडरस्टैंडिंग, जब तक एल्बुमिन ब्लड के अंदर है, व्हाट इज गोइंग टू हैपन? दिस ब्लड इज नॉट गोइंग टू लीक आउट. ये ब्लड को गाढ़ा कर रहा है. दिस इज गोइंग टू मेक द ब्लड थिक. एज सुन एज यू आर गोइंग टू हैव लिवर डैमेज, ओके, सिरोसिस हो गया, या फिर वन मोर डिजीज वी विल बी डिस्कसिंग टुमारो इन नेफ्रोटिक सिंड्रोम. सो व्हाट इज गोइंग टू हैपन? एल्बुमिन गया, एल्बुमिन नेफ्रोटिक सिंड्रोम में क्या होगा? प्रोटीन यूरिया होगा, एल्बुमिन बाहर चला गया. व्हाट विल हैपन? दिस फ्लूइड विच इज देयर नाउ, दिस फ्लूइड विल बी कमिंग आउट into the interstitial space, and this fluid will be getting accumulated here, and that is why the person will be having what, ascites. This patient will be having what, ascites. उस patient में क्या हो जाएगा, ascites हो जाएगा, पानी क्या हो गया, blood vessel से निकल के बाहर आ गया, accumulate हो गया. If it is accumulating into different cavities, we call it different names, but the ultimate treatment will be what, whenever you are doing paracentesis or anything like that, whenever you are removing a lot of fluid, what you should be done, you should be giving albumin. Otherwise what will happen, अगर किसी में से आपने 2 लीटर पानी निकाल लिया, सपोज if you are extracting, you are doing paracentesis or you are just what will happen, the patient might die, patient might land up into shock, right? So to prevent that, we are giving salt free albumin to the patient, we are giving salt free albumin to the patient, right? So these are the things you should be remembering, right? Basic चीजें याद रखनी है. Now try to solve this question, very classical question. As 37-year-old male patient is brought to the emergency after the New Year party. तो अभी जैसे हो रहा था, right? The patient is having the chest pain, right? The patient is having the chest pain along with the vomiting, retching episodes of vomiting. And on examination, we noted that there is subcutaneous emphysema and he is having feeble pulse. Feeble pulse matlab low pulse hai. Pulse is the representation of your heart, right? And the patient is also having the BP, low BP, hypotension. On auscultation, we are hearing some sound. What are these sounds? These are your crunching sounds. Crunching sounds will be there, right? And it is noted. And what is the diagnosis in this particular case? Try to answer, right? So what is happening in this particular patient? We are having a case of upper GI bleeding. This is a case of upper GI bleeding. This patient is having upper GI bleeding. Upper GI bleeding किसको बोलते हैं? The bleeding happening above the ligament of treats. Okay, so if the bleeding is happening proximal to ligament of treats, this is known as अपर जीआई ब्लीडिंग. दिस इज नोन एज अपर जीआई ब्लीडिंग. अब अपर जीआई ब्लीडिंग में क्या हो सकता है? वी कैन हैव द ब्लड कमिंग आउट फ्रॉम द माउथ. दिस इज नोन एज हेमाटमेसिस. Hematmesis can happen, or if this bleeding is happening at the level of upper GI bleeding, right, and this is going below, then it will be mixing up with the acid, base, everything, right, and it will be making what, black tarry stool. What do we call it? Yes, we call it melena. That is going to be your black tarry stools, black stools, right? Here you will be having fresh blood. Hemoptysis matlab the blood is coming out in the sputum. Okay, this is going to be your fresh blood. Okay, so now let's try to understand what is this Mallory-Weiss tear, what is this Boerhaave syndrome. Okay, so both of these things can happen after episodes of binge drinking. Okay, so what is the thing that is going to be common here? You can have binge drinking. Binge drinking is a common thing. You can appreciate here also binge drinking. Apart from that, this is going to be a longitudinal superficial tear. Remember Mallory-Weiss tear, it is a tear. It is a Mallory-Weiss syndrome is a tear. Superficial tear will be there. Okay, और ये tear कहाँ पर होगा? This tear will be present in the submucosa. This tear will be present in the submucosa. तो किसी ने बहुत ज़्यादा alcohol लिया and the patient is having a tear. Because of that tear, he can have bleeding from the mouth, right? He can have hematemesis, not so much, but yes, he can have, right? So that is going to be the submucosal tear. एक क्वेश्चन पूछा था, the source of bleeding will be what? The source of bleeding here will be left gastric artery. The source of bleeding will be left gastric artery, right? In Boerhaave syndrome, there will be a specific triad that you have to see, that is known as Meckler's triad. Anyone try to answer what is Meckler's triad? What is Meckler's triad? Okay, and here the rupture will be transmural. Here the rupture will be transmural. Transmural rupture will be there. Transmural rupture will be there. Then how you are going to proceed for the Boerhaave syndrome? The investigation of choice in this particular case, it is a transmural rupture, so everything will be going out, right? So into the mediastinum, right? So what you will be going, you will be doing CECT. On chest x-ray, you will be finding what? continuous diaphragm sign on chest x-ray. You will be finding continuous diaphragm sign, right? Because of what? Mediastinitis. This sign is happening because of mediastinitis. And how you will be treating this particular situation? For the treatment, you need to do surgical exploration. You need to do surgical exploration for the treatment of this particular thing, right? What is this macular striate? Anyone? Very good. Dr. Raz, Dr. AZ, right? So macular striate will be, the patient will be having chest pain, patient will be having subcutaneous emphysema, subcutaneous emphysema, and patient will be having vomiting, bloody vomiting, hematemesis, right? A retching. What is the meaning of retching? That means he want to vomit out but nothing is coming. He is having nausea, he want to vomit out but nothing is coming. That is known as retching episode, right? So in the question we have already have the symptoms. This is your chest pain, this is your vomiting, and this is your subcutaneous emphysema, right? All these are signs of what? All these are signs of macular striate. All these are signs of macular striate. So this is going to be in the favor of Boerhaave syndrome. You will also find, you will study in surgery, you will be having Hammond sign, crunching sound, okay, on auscultation. Why this Hammond sign or walking in a snow sign? That is because of this subcutaneous emphysema, air की वजह से हो रहा है. Why this air? This is because of pneumomediastinum. Pneumomediastinum, right? Pneumo मतलब air, mediastinum के अंदर air है. That is why you are having that sign. On chest x-ray you will be getting a continuous diaphragm sign. Normal as a continuous diaphragm sign will be there, and these are the symptoms you will be having in the cases of Boerhaave syndrome, right? Why this is not a case of variceal bleed? Variceal bleed कहाँ होता है? Variceal bleed you will be seeing in the cases of like not pulmonary, in the cases of portal hypertension, in the cases of things like you will be having hepatosplenomegaly will be there, in the cases of like cirrhosis will be there, right? So basically these things are seen in the cases of chronic liver disease. Chronic liver disease, when you are going to have this splenomegaly component, or you can have things like cirrhosis और things like portal hypertension. तो जब ये चीज़ें होंगी, पोर्टल हाइपरटेंशन होगा, सिरोसिस होगा, तो क्या होगा? यहाँ पर वेन्स के अंदर प्रेशर बढ़ेगा, ईसोफेगस की वेन्स के अंदर प्रेशर बढ़ेगा, एंड दे विल गेट डायलेटेड. सो यू विल बी हैविंग सुपरफिशियल डायलेटेड वेन्स. एंड व्हेन आई हैव टॉट यू, वेन एवर अ वेसल इज डायलेटेड, व्हाट विल हैपन? समथिंग विल कम आउट. इन द फिजियोलॉजी वी हैव डिस्कस्ड, राइट? तो कुछ ना कुछ बाहर आएगा. क्या बाहर आता है? ब्लड बाहर आता है. दैट इज गोइंग टू कम आउट, राइट? दैट इज नोन एज हेमाटेमेसिस, हेमाप्टेसिस. व्हाट इज हैपनिंग? बिकॉज ऑफ द superficial dilated vessels, right? So this is going to be the variceal bleed. Variceal bleed. So the drug you can use terlipressin, which is going to be a V1 receptor. V1 is going to be your terlipressin. V1, V2, V3 पढ़ा था. V1 is terlipressin, V2 desmopressin in the cases of ADH, right? And V3 for the activation of ACTH, right? And the drug of choice is going to be your octreotide, which is a somatostatin analog. Okay, so this is going to be this particular thing. What about this peptic ulcer disease? Peptic ulcer disease can have two manifestations. Two things can bleed in peptic ulcer disease. Two types of ulcer. Either the ulcer is present in the gastrium region, either the ulcer is present in the colon. Okay, so gastric ulcer can be there, and duodenal ulcer can be there. Gastric ulcer, the artery which is going to bleed is going to be left gastric artery. In duodenal ulcer you will be having gastroduodenal artery which is going to get bleed. How many types of peptic ulcer do we have? We are having things like, okay, let me make you understand what is peptic ulcer. So peptic ulcer, we are having three types of peptic ulcer. Basically we are having three types of gastritis. Okay, gastritis is the inflammation. We are having type A, type B, and type C. A is going to be your autoimmune. And what are the antibodies? Antibodies are going to be antiparietal cell antibody. B is going to be your bacterial. What is the bacteria that is going to cause the disease? That is going to be your H. pylori, Helicobacter pylori. Or this Helicobacter pylori is going to do what? So in GIT we are going to have three cells. We are going to have first one, this is going to be your M1 receptor where acetylcholine will be working. Second one is your H2 receptor where histamine will be working, and third one is your gastrin, G cells where gastrin will be working. All these three things are going to increase the acid production, right? Which is the thing which is going to decrease the acid production? This is your ionized set question, that is going to be your somatostatin. Somatostatin, and second is your negative reflux, negative feedback you can say, right? So what is happening? This H. pylori is going to damage the delta cells. This H. pylori is going to damage the delta cells, and delta cells are going to secrete somatostatin. And somatostatin का function क्या होता है? I have taught you, somatostatin हमेशा inhibitory होगा, राइट? जहाँ भी जाएगा सबको इनिबिट कर देगा. तो somatostatin का काम होता है गैस्ट्रिन को इनिबिट करना. But now what is happening? We are having H. pylori, and this H. pylori is going to damage your delta cells. Now what is going to happen? There will be no somatostatin, there will be increased levels of gastrin. And this increased levels of gastrin is going to cause what? Increased levels of HCl, and that is what is responsible for the ulcer production. Okay, and this H. pylori is going to be seen under a silver stain, that is going to be your Warthin starry silver stain, and it can also cause cancer. What is the cancer that it is going to cause? That is going to be your maltoma, mucosal associated T cell lymphoma, or gastric adenocarcinoma, right? And what is the treatment you would like to give? Adenocarcinoma. Okay, what is the treatment you would like to give? That is going to be your cap therapy. One is clarithromycin, second is amoxicillin, and third one is going to be your PPI, cap therapy. और क्वाड्रिपल में क्या ऐड कर दोगे? बिस्मथ सबसिट्रेट या फिर सक्रalfate, that is going to be the bacterial. C is going to be your cytotoxic, that is the quick revision. C is going to be your cytotoxic or chemical induced or NSAID induced ulcer, right? That is going to be your NSAID induced ulcer, right? इसके लिए एक क्वेश्चन पूछते हैं, what is the most specific drug that you can use? Most specific drug, that is going to be your misoprostol, right? Apart from that, any other case, we are also having G cell gastrinoma, also known as Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is what? G cell का tumor हो गया, that is known as Zollinger-Ellison syndrome. Drug of choice will be PPI. Drug of choice will be PPI. Okay, G cell gastrinoma. Okay, rest you will be studying about this particular thing in the surgery as well, right? So I'm not going into detail. So in this particular case, what will be your answer? Here your answer will be Boerhaave syndrome. These things can these ulcers can also, like peptic ulcer can also bleed, right? And they are generally presenting with the melena. So whenever the person is coming to you with the black terry stools and patient is having pain, you can already assess. I hope you know when to assess whether it is a gastric ulcer, whether it is a duodenal ulcer. अगर पेशेंट को खाते ही पेन हो रहा है, दैट मीन्स पेशेंट इज हैविंग गैस्ट्रिक अल्सर. अगर खाने के बाद में पेन रिलीव हो रहा है, मोटा पेशेंट है, बहुत सारा थोड़ा थोड़ा टाइम में खाता है, दैट इज गोइंग टू बी योर duodenal ulcer, right? Okay, so next question we are having, a 34-year-old female patient is presented to OPD with the complaints of fever. Patient is having what? Fever, abdominal pain is there, diarrhea is there, joint pain is there. She is also having skin rashes, ulcer formation. On radiological examination, you are going to have loss of ostrations of large intestine. Loss of ostrations on large intestine. Basically, large intestine will be having these type of structures. These are known as hostra. Okay, अगर ये hostrations absent, if these hostrations are absent, this is going to be which disease? This is going to be which disease? D. Everyone is agreeing with the ulcerative colitis, right? So let me make a quick revision for the ulcerative colitis. Look here, right? So we are having two IBDs. These are your inflammatory bowel diseases. One is going to be your ulcerative colitis, another one is going to be your Crohn's disease, right? So in Crohn's disease and ulcerative colitis, what are the important pointers that we need to see? Look here, what is the location? So you can simply remember, Crohn कहीं भी हो सकता है, Crohn कहीं भी हो सकता है. You will be having from mouth to anus, that is complete alimentary canal. Crohn can happen anywhere. Crohn can happen anywhere. Crohn can happen anywhere. You can remember like that. So you will be having what kind of lesion? Suppose यहाँ lesion है, यहाँ lesion है, यहाँ lesion है, right? So you will be having what kind of a lesion? These are known as skip lesions. These are known as skip lesions, whereas ulcerative colitis will start from the below. Ulcerative colitis will start from the below. It will be starting from the colon or rectum. Normally does not spread beyond ileum, right? Here you will be having transmural inflammation. Transmural matlab आर पार, right? Suppose these are your 4 layers of the GIT. So this can cause transmural inflammation, whereas this can cause only superficial inflammation. Ulcerative colitis में क्या होंगे? सिर्फ ulcers होंगे, right? But this particular Crohn's disease can present with the penetration or perforation also, right? Apart from that, we are having histology. You will be finding crypt abscess here. Here you will be having granuloma increased in the goblet cells. Smoking is a protective factor. Smoking is only a protective factor in this particular disease, that is going to be your ulcerative colitis, right? Here you will be having erythema nodosum, pyoderma gangrenosum, arthritis and ocular manifestations. Here also you can have these things, right? On endoscopy, endoscopical findings are important. You will be having continuous lesions here, whereas here you will be having these skip lesions. Okay, and complications क्या हो सकती है? Here we can have stricture formation, fistula formation, fissure formation, right? It can even lead to cancer, right? Here also we are having toxic megacolon, thromboembolism, and there is also increased risk of colorectal cancer. It is associated with primary sclerosing cholangitis. Very very important thing, you have to remember this. And this is associated with the gallstones, right? Ulcerative colitis में एक special appearance मिलती है, that is known as lead pipe appearance, which is nothing but loss of ostrations. Whereas here you will be finding a special appearance on radiology, that is known as string sign of Cantor. String sign of Cantor, right? Or cobblestone mucosa. on endoscopy you will also find cobblestone appearance. These are the important points of this particular thing, right? Now let me talk about the treatment also. So basically what is going to happen, this is your colon में क्या होता है? There are only two important things. अगर यहाँ पर let's say this is your stool, यहाँ पर stool will be going out because of two things. Let me make you understand. जब भी कोई भी चीज़ इसको irritate करेगी colon की layer को, what will happen? There will be increase in the movement. Whenever anything is going to irritate your bowel mucosa or your large intestine mucosa, what is going to happen? You will be having increase in the movement, right? And second thing, this is your stool. What will happen? First you will be having preformed stool. ये preformed stool होता है, right? Because you must have seen, sometimes you guys are having diarrhea. What will happen? You will be having this watery stool is coming out, right? Then what will happen? This stool will be having absorption of water. This water will be absorbed here, and then it will be making what? Complete stool. That is going to be the thing, right? Now what is going to happen? Those patients who are having ulcerative colitis, they are having what? They are having this tightness of this movement again and again. They are having this movement because they are having some kind of ulcers over here, and they are having ulcers and they are having movement again and again. And what kind of stool they will be passing? They will be passing pre-formed type of stool, right? So this type of patient, we are going to use what? We are going to use 5-amino salicylic acid derivative. That is going to be your drug of choice. That is going to be your sulfasalazine. Sulfasalazine is the drug of choice. How it is going to help? It is going to do what? It is going to make the covering. It is going to decrease the inflammatory mediators, right? And that is why it is going to be the drug of choice. ये inflammatory mediators को कम कर देता है, यहाँ का movement कम हो जाता है. अगर movement कम हो जाता है तो patient will be going less, right? He is going less for defecation and the patient will be relieved, right? तो इन पेशेंट्स को बार बार अर्ज होती है, समटाइम्स दे आर हैविंग स्टूल, समटाइम्स दे आर नॉट हैविंग स्टूल, बट दे नीड टू गो अगेन एंड अगेन, राइट? और बार बार जाने की वजह से दे विल बी हैविंग दिस ट्रेनिंग, राइट? एंड दिस ट्रेनिंग इज गोइंग टू कॉज मोर अल्सर फॉर्मेशन, राइट? सो दैट इज व्हाट इज द साइकिल. टू स्टॉप दैट वी कैन यूज sulfasalazine. We can also use steroid in this particular case. Other drug that we can use is steroids. I'm not giving you the false hope, Shubham. If you are able to solve this type of question, after this please try to solve the questions that has been asked in your previous examination. You will be able to understand, right? Second thing, and I am glad you are finding these questions easy, right? Here in this particular case, in the cases of Crohn's disease, we are having the treatment. What is the treatment we are going to give? The treatment that we are going to give is going to be your steroid. Okay, the treatment that we are going to give is your steroids, and if steroids are not working, then we are going to go for biologics. What are these biologics? Like drugs like infliximab, etanercept, okay, certolizumab, adalimumab, certolizumab. So these are the drugs we are going to use for the cases of Crohn's disease, right? These are the two important things. Then we are having what? Whipple's and celiac sprue, right? So let me make a table for malabsorption syndromes. So malabsorption से एक क्वेश्चन तो वो पूछते ही है, malabsorption. The important things, one question they will ask generally about the Whipple's, or sometimes about the celiac, or sometimes about the tropical sprue, right? So let me make a table for celiac disease, tropical sprue, and Whipple's disease. Okay, so these are the three things. First, celiac disease. Why this thing is happening? This is a gluten insensitivity syndrome. This is a gluten. ये लोग क्या नहीं खा पाते? Gluten insensitivity. What are the things which are having gluten? क्या avoid करना है इन लोगों को? What are the things they need to avoid? What are the things that are the causes? शुभम, फिर तुम मिठाई का डब्बा रेडी रखो भाई, राइट? इफ यू आर एबल टू सॉल्व ऑल दिस क्वेश्चंस, आईएनआई सेट के भी लगा दिए, you will be acing the exam, right? Causes will be bro. What are the antibodies we are having? We are having antibodies that is going to be your anti-TTG, anti-tissue transglutaminase, anti-endomysial antibody, anti-gliadin antibody. ये तीन याद रख लो, anti-tissue transglutaminase, anti-endomysial, anti-gliadin antibody. And it is also going to be associated with one disease and certain HLAs. The disease which is having association, I've taught you in dermatology as well, that is going to be your dermatitis herpetiformis. Dermatitis matlab inflammation of the skin, herpeti matlab grouped vesicle on the extensor surface near the arm, both the bilateral arms and around the knees, right? Extensor surface, that is going to be dermatitis herpetiformis. Apart from that, it is going to also have association with the HLA DQ2. My pencil is gone. Just give me 5 minutes and let's talk till then, right? Let me just explain you, right? So you will be having these things. What are these things? Dermatitis herpetiformis will be having what? You will be having multiple grouped vesicle over the extensor surface. It is associated with the celiac disease, and this particular thing will be having what? The drugs that you would like to use. What is the drug of choice? That is going to be your dapsone. And what is the treatment of choice? The treatment of choice is to avoid the bro. What is bro? Barley, rye, oat and wheat. इन चीज़ों को avoid करना है. Okay, so that is what we need to do, right? So this is your celiac sprue. Celiac sprue में क्या होगा? पेशेंट क्या नहीं खा पाएगा? बार्ले, राई, ओट्स और व्हीट, इन सब को छोड़ के बाकी चीज we need to avoid these type of things. Otherwise, what will happen? The patient will be having problems, right? You can also do biopsy. On biopsy, what you are going to find? There will be crypt hyperplasia with villus atrophy. Will be there. Okay, tell me, where do you have the absorption of iron? Iron I've taught you. Where do you have the absorption of folic acid? Folic acid और vitamin B12 का absorption कहाँ होता है बताओ? You all will pass. Shubham, Mohammed, Shanawaz. Wonderful, guys. Okay, tell me, where do you have this particular thing? Thank you, Vedagi. Okay, so let's begin. Very good, guys. It is jejunum for the cases of like folic acid absorption, and it is also happening at the level of duodenum also, but some the most appropriate would be jejunum now, right? And apart from that, terminal ileum for the vitamin B12, right? What is the HLA association we are going to have? That is going to be your HLA DQ2 and DQ8. DQ2 and DQ8, very very important. Dermatitis herpetiformis, you will be having papillary tip microabscess. I've told you there will be accumulation of uh, abscess in the level of papillary tip, right? On biopsy, hallmark on biopsy, you will be having this villus atrophy. Very very important, guys. Villus atrophy with crypt hyperplasia. Crypt hyperplasia. The drug of choice, I have taught you, in the dermatitis herpetiformis, you are going to give what? That is going to be your dapsone, sulfonamide, and you can also use the treatment of choice for this particular thing is going to be your avoiding the substance, avoiding the barley, rye, oat, and wheat. That is going to be avoiding the bro is going to be the treatment, right? For the tropical sprue, this is basically a type of a bacterial infection. This is due to Giardia lamblia, or okay, Giardia lamblia. It can be due to, sometimes it can be due to E. coli as well. Those people who are coming from, we are immune, we are eating golgappas outside, right? We are immune, but those people who are coming from outside, they can have tropical sprue from this E. coli also, right? What kind of a diarrhea you will be having? You will be having osmotic type of diarrhea. In Giardia, you will be having statoria. I have taught you how this statoria is happening, right? And remember this thing, tropical sprue is going to damage your which part? Jejunum part, right? So you will be having specifically deficiency, more likely for the folic acid. More likely folic acid deficiencies will be there. You can also have deficiency of vitamin B12, but folic acid will be more. Investigation of choice, you can do gut biopsy. And the treatment, you can use antibiotic. That is going to be your, you can also use tetracyclines, but you need to give it for a longer period of time. That is going to be the tropical sprue, right? Yes, what is the motility? That is going to be your falling leaf like motility. Giradia, patta giradia, I have taught you, right? And it will be having how many pairs? How many pairs of flagella? Fatty stool. Why this fatty stool is coming? Okay. Next one, we are having Whipple's disease. That is going to be because of Trophirema whipplei. Trophirema whipplei. Trophirema whipplei is the bacteria which is going to cause what? Whipple's disease. Here on investigation of choice is basically biopsy here also, right? You will be having what? Pass positive macrophages. You will be having pass positive macrophages. Okay, pass positive macrophages will be there. And the drug of choice for this particular case, you will be giving what? You will be using third generation cephalosporins like ceftriaxone. Okay, but this Whipple's can also be present with the CNS or CVS symptoms. This particular word you have to remember on the biopsy. On the biopsy, what is going to happen? This is important. On the biopsy, you will be having pass positive macrophages, right? Trophirema whipplei. That is going to be the Whipple's disease. Okay. Now we are having a question from the pulmo part. That is going to be a 32-year-old male patient is presented to emergency with the symptoms of respiratory distress. This patient is having respiratory distress. So stomach ache is there. पेट में दर्द है. Cough is there. He is coming to you. You are the doctor, right? Cough is there. Fever is there. Anosmia is there. What is that? Anosmia. सुना सुना लग रहा है, right? And it is also noted that the X-ray is showing bilateral ground glass appearance opacities, right? On X-rays you are having white ground glass opacities, white out lungs, right? This is very, very characteristic. Whiteout lungs on x-rays are characteristic of what I've told you. That is going to be respiratory distress, right? सफेद normally air should be present in the lungs. It should be looking black, right? Air कैसे दिखती है? Black दिखती है. But if your lungs are looking white, these are known as whiteout lungs, and they are suggestive of what? ARDS. They are suggestive of acute respiratory distress syndrome. If I talk about baby, if I talk about children, that newborn baby, what would be that? That would be your hyaline membrane disease, respiratory distress syndrome in the baby, right? Due to deficiency of surfactant, right? So what is it? This is going to be your what kind of respiratory failure? SpO2 कितना है यहाँ पर? Anyone tell me the diagnosis? What is your diagnosis? What is your diagnosis? लॉकडाउन हुआ था, लॉकडाउन में कौन सी डिजीज हुई थी? दैट वाज योर कोविड-19. दैट वाज योर कोविड-19. कोविड-19 में ही तो हुआ था रेस्पिरेटरी डिस्ट्रेस, एनोस्मिया. एनोस्मिया मतलब देर विल बी देर देर विल बी व्हाट? एनोस्मिया मतलब क्या हो गया? खुशबू नहीं आ रही है, राइट? वी आर हैविंग कफ एंड फीवर ऑल्सो अलोंग विद दैट, राइट? सो दिस इज गोइंग टू बी द diagnosis, right? So let me make a table for respiratory failure. You know what is respiratory failure? Let me make you understand. So respiratory failure, we are having type 1 respiratory failure, type 2 respiratory failure, type 3 and type 4. Okay, so what are the peculiar features about all of them, so that you will be able to solve question, right? So in type 1, remember, in type in type 1, what is going to happen? The patient will be hyperventilating. The patient will be hyperventilating. The patient will be hyperventilating, but there will be decrease in the partial pressure of oxygen, right? Why? Because this patient is ventilating so fast. Tachypnea is there, but the tachypnea is so fast. He's taking shallow breathing, he's taking fast shallow breathing. Because of that, what will happen? PO2 is going to get decreased, right? Other things, either CO2 can be normal or it can be decreased also. PCO2 can be normal or decreased also, right? Tachypnea will be there, faster breathing will be there, tachypnea, and this tachypnea will lead to decrease in the partial pressure of oxygen, right? This is going to be the presentation for the type 1. This is going to be the presentation for the type 1 respiratory failure, right? What are the example? Where do you find this particular situation? In the cases of pneumonia. What you see in the cases of pneumonia, the patient is having rapidly breathing, but this rapid breathing, this hyperventilation is not the deep breathing, right? So the patient will be having low PO2, right? Apart from that, this thing is also happening in the cases of ARDS. Okay, this thing is also happening in the ARDS, right? In the cases of asthma, also, right? In the cases of COVID-19, or you can also remember emphysema. In the cases of emphysema, in the cases of ARDS, your pneumonia, your asthma, your COVID-19. So all these things are going to go in the favor of type 1 type of ARDS. If you don't remember what is happening, you can simply remember the patient will be hyperventilating, and all these things you can remember. One more you can remember, that is going to be your fat embolism, right? What will happen in the type 2 type of respiratory failure? Here the patient will be hypoventilating. यहाँ पर patient क्या होगा? Hypoventilate करेगा. Hypoventilating, and of course if he is hypoventilating, there will be decreased partial pressure of oxygen. Okay, and there will be increased CO2. Here increase in CO2 means what? I have told you, CO2 का भाई कौन है? H plus. Always remember this simple understanding. CO2 का भाई H plus है, so you will be having respiratory acidosis. H plus बढ़ेगा तो क्या होगा? CO2 बढ़ गया तो H plus बढ़ गया. If there is increase in CO2, there will be increase in H plus. That would be leading to respiratory acidosis. Okay, what are the examples we are having here? We are having examples like chronic bronchitis. We are having tension pneumothorax. Next, tension pneumothorax. we are having diaphragmatic paralysis or diaphragm paralysis. We are having cases like obstructive sleep apnea. Here you will be having this type 2 type of respiratory failure. Type 3 में क्या होगा? Type 3 there will be after some post-op. When you go into hospital, the patient will be coming and they will be simply talking about type 1 and type 3. Type 1, type 2, type 3 respiratory failure. You have to think in the terms of what is happening. Okay, so in type 3, what is going to happen? Post-operative patient will have what? Dilatation of alveoli. And this dilatation of alveoli is known as what? This is known as atelectasis. This is known as atelectasis. This is known as atelectasis, right? So this patient will be having atelectasis. For the treatment of this particular thing, we are going to give oxygen plus the chest physiotherapy. Basically there will be some dilatations on the alveoli, right? It should not be there. Normally alveoli should contract, right? Contract and dilate, right? But here there are some dilatations, and that is what is leading to this particular thing, atelectasis, right? So you need to give what? Chest physiotherapy along with the oxygen. What will happen in the type 4? The patient will be the patient of shock patient. Let's say shock means what? There will be hypoperfusion to the organs. Shock का मतलब क्या होता है? ऑक्सीजन नहीं पहुंच रहा है, right? BP will be low, there will be feeble pulse, BP will be low, right? Multiple types of shock you are having, hypovolemic, cardiogenic, right? But the BP will be low, there will be decrease in the perfusion. And why this decrease perfusion मतलब क्या होता है? टिश्यू के पास ऑक्सीजन कम पहुंच रहा है, right? And why this thing is happening? Because of decrease in the cardiac output. And this decrease in the cardiac output will lead to decrease in the Q, और Q को भी बोलते हैं perfusion. ओके, और इसकी वजह से क्या हुआ? हाइपोक्सीमिया हुआ. So what we need to do in this particular case, for the treatment we need to intubate our patient. So we need to give endotracheal intubation. ET tube डाल देंगे. ET tube डालने के बाद में you will be doing what? Intermittent positive pressure ventilation will be given, right? So you will be giving IPPV here, right? So this is going to be the type 4 thing. All right. ET tube will be there, and then we can give the IPPV. Okay. Now, very important question, right? That is going to be a 34-year-old male patient, alcoholic male patient presented to emergency with the symptoms of fever. Patient is having fever, non-productive cough. Definite one question will be there in your exam. Okay, very important question. Difficulty in breathing. Patient is having difficulty in breathing. We call it what? Dyspnea. Difficulty in breathing is going to be your dyspnea. On chest x-ray, we found consolidations. There will be consolidations on the chest x-ray, and infiltrate, which can be the possible organism responsible for this, right? So what is your diagnosis? First of all, what is your diagnosis? Mycoplasma. This is going to be very good, Shubham. This is going to be pneumonia. All of you are answering wrong. Let me make you correct. Okay, let me make you correct. This is a case of pneumonia. Let me make you understand how to approach the case of pneumonia. Definite question will be coming in your exam, right? So pneumonia में क्या चीज़ें याद रखनी है? Pneumonia can be बेटा typical हो सकता है और atypical हो सकता है. Pneumonia can be typical or atypical. Just remember simple word that I am telling you. अगर क्वेश्चन के अंदर दे रखा है consolidation, अगर क्वेश्चन के अंदर दे रखा है, इफ द क्वेश्चन इट इज रिटन consolidation, that means it is a case of typical pneumonia. And what I've taught you, the most common cause for meningitis is pneumococcus. Most common cause for typical pneumonia is also pneumococcus is the most common cause for typical pneumonia. What about sir atypical pneumonia? Sir, this is also known as walking pneumonia. This is also known as walking pneumonia. इसमें क्या होता है, COVID-19 में we had pneumonia, right? So what was happening? Patient घूमता रहता है, patient को पता नहीं होता. When we go for HRCT scan, we find out 70% of the lungs are damaged, right? This is the atypical pneumonia. Symptom तो same होंगे, but symptoms कम होंगे, disease ज़्यादा होगा. Here disease will be more and the symptoms will be less. That is why it is known as walking pneumonia. The most common cause for walking pneumonia is going to be your mycoplasma, right? And second, viral में बात करूँ, that is your COVID-19. Multiple we are having, but these are important one, right? So this is the basic approach. Now what you need to understand, look here, what are the different bacteria? Let me make you understand. So different case scenarios. देखो निमोनिया के ऊपर क्या क्या क्वेश्चन पूछ सकते हैं. फर्स्ट क्वेश्चन दे कैन आस्क यू मोस्ट कॉमन कॉज ऑफ निमोनिया. मोस्ट कॉमन कॉज ऑफ निमोनिया. नाउ यू हैव टू आंसर मी फास्ट. फटाफट टाइप करो व्हाट इज द मोस्ट कॉमन कॉज ऑफ निमोनिया. दैट इज गोइंग टू बी pneumococcus. That is going to be your pneumococcus. Yes, treatment will be azithromycin. Why we are giving azithromycin? Because this is a bacteria. mycoplasma एक बैक्टीरिया है जिसके पास सेल वॉल नहीं है. अगर सेल वॉल नहीं है तो क्या तुम्हारी सेल वॉल सिंथेसिस इनहिबिटर्स लाइक योर cephalosporin, ceftriaxone, cefixime, amoxicillin, nothing is going to work, right? Because it does not have cell wall, right? That is why we are using what? That is why we are using azithromycin. Even in the cases of COVID-19 also, it was a viral disease. COVID was a viral disease, but still we are using azithromycin to prevent this particular thing, right? So most common cause of pneumonia is going to be your pneumococcus. If they ask you most common cause of nosocomial pneumonia, nosocomial मतलब hospital acquired. Nosocomial pneumonia, most common cause is going to be what? It is going to be your Staph aureus. Staph aureus. Any bone infection, osteomyelitis. What is going to be your answer? That is going to be Staph aureus. Most common cause of ventilator associated pneumonia. ये ventilator के अंदर रहता है. That is going to be your Pseudomonas. And Pseudomonas is a very nasty bacteria. It can grow in the Cetrimide agar, which is a disinfectant. ये grow कहाँ करता है? Cetrimide agar के अंदर, right? Second, you can remember that is your Acinetobacter, right? Apart from that, they can give you a question: alcoholic patient, and on X-ray they can give you certain sign. What are these sign? Alcoholic patient. Very good, Shamil. What you are understanding about alcoholic patient? Here you will be having bulging fissure sign on chest X-ray, on CXR, and red currant jelly sputum. What is going to be your diagnosis? Your diagnosis will be Klebsiella. Okay, diagnosis will be Klebsiella, right? One more question they have asked you: central AC. Last exam question, central AC, or they can also ask you central AC or contaminated water. Central AC, contaminated water, and the culture media is BCA. Answer will be culture media is BCA, buffer charcoal yeast extract. AC कंटामिनेटेड AC अगर दे रखा, सेंट्रल AC दे रखा है, या फिर ऐसा बोलेंगे कि द पर्सन इज वर्किंग इन अ एनवायरमेंट विच इज़ अ फुल्ली सेंट्रलाइज्ड AC सिस्टम, राइट? दे विल मेंशन, राइट? यू हैव टू थिंक इन द केसेस ऑफ, यहाँ पर क्या होगा? लीजेंड्स आर लिविंग इन द AC, राइट? सो दिस इज गोइंग टू बी योर लीजियोनेला. Okay, that is going to be your Legionella. अगर बर्ड हैंडलर है, if someone is a bird handler, सिट्टकोसिस ऐसा कुछ दे रखा है, that is going to be your chlamydia. Right? If they have given you question like COPD with pneumonia, और polymorphic colonies दे रखी है, that is definitely going to be Haemophilus influenza. Haemophilus influenza, right? Now the most important thing, HIV positive patient. HIV positive patient, based on the amount, based on the number of CD4 count, they are having different manifestations, right? If CD4 count is less than 50, this is going to be in the favor of CMV or MAC, Mycobacterium avium complex or intracellular, right? If CD4 count is less than 100, that is going to be in the favor of toxoplasma. If CD4, no zero AC, zero AC will be coming if CD4 count is less than 200, that is going to be your pneumocystis cerevisiae, pneumocystis cerevisiae or plasma cell pneumonia, also known as PCP, plasma cell pneumonia. Here you will be having that ping pong ball appearance on the gomori methiamine silver stain, right? If CD4 count is less than 500, the most common opportunistic infection that is going to happen is going to be nothing but your tuberculosis. Apart from that, HIV positive patient, meningitis, that is going to be your cryptococcal meningitis, right? HIV positive patient with massive watery diarrhea, let me write it for you, massive watery diarrhea, that is going to be your massive watery diarrhea. HIV positive patient, that is going to be your Cryptosporidium parvum, okay, Cryptosporidium parvum. And meningitis, HIV positive patient with meningitis, that is going to be your Cryptococcus neoformis, okay. I hope you are not going to make any mistakes now, okay. So these are the basic pneumonia etiologies they are asking, right? Now what is that particular score that we are using for identification of the risk? That is known as curb 65 score. This is the score you guys are going to use to identify whether you need to uh, admit your patient or you need to manage it on a conservative management at home, right? So C is going to be for the confusion. U is going to be blood urea nitrogen. It should be if it is more than 7, right? Blood urea nitrogen. R4, that is going to be the respiratory rate. R is going to be the respiratory rate if it is more than 30. Respiratory rate will be high, टेकिपनिया will be there, but it is a shallow breathing, इसलिए बोलते हैं कम सांस लो लेकिन गहरी सांस लो, okay? So that is going to be the deep breathing, इसीलिए बोलते हैं, right? Next we are going to have B is going to be the BP less than 90 systolic and less than 60 diastolic, that is going to be the BP. And if age is more than 65, that is going to be the, okay, that is going to be the curve 65 score, that is going to be the curve 65 score, right? 65 is the age. अब इसका इंटरप्रिटेशन कैसे करोगे? 5 नंबर है, अगर 0 to 1 आ रहा है, अगर 0 to 1 आ रहा है, you can remember outpatient, you can remember like that also, OPD basis पे treat करोगे. This is a low risk patient, okay? So you can give for the home treatment. यहाँ पर क्या करोगे? home treatment दे सकते हो. If patient is having number 2, that is going to be, now you need to take on the inpatient IPD basis पे कर लो, और या फिर close monitoring. अगर OPD पे कर रहे हो, that is going to be the close monitoring need to be done, right? अगर 3+ है, if it is more than 3, then definitely you need to send him to the ICU, and this is a severe case where you need to admit the patient and you need to treat him well, right? ICU में admit कर लो and then you need to give the treatment. So whenever a patient is coming to you in your hospital after this exam, I hope you all will clear, you will join your internship, and when a patient is coming to you with a chest pain, the patient will be telling you the symptoms, or I am having cough from like so many days, right? Now I'm having cough, I am having headache, I am having these type of fever, difficulty in breathing, all these things, tachypnea will be there, high respiratory rate, and he is coming to you, and then you need to understand what is this particular patient is having. This patient is having, either the patient can have typical or atypical pneumonia, right? Atypical वाले तो ऐसे आएंगे नहीं, atypical वाले आएंगे सीधा CT स्कैन करवाएंगे, and they will be having like in COVID-19 what was happening, उनका आधा से ज़्यादा लंग पहले ही खराब होता है. Typical patients will be having, when you see the X-ray, you will be finding the consolidations, okay? न्यूमेटोसिल्स मिलेंगे, स्टैफ ओरियस के इन्फेक्शन में यू विल बी हैविंग द न्यूमेटोसिल्स, रेड करंट जेली स्पूटम, बल्जिंग फिशर साइन मिलेगा अगर क्लेप्सिला अल्कोहलिक पेशेंट है. सो दीज आर द स्पेसिफिक फाइंडिंग्स you will be having, right? So you will be doing the examination and how you will assess the patient on the curve 65 score, right? अगर वो patient को curve 65 score पे assess करोगे, 3 से ज़्यादा नंबर आ रहे हैं, you will be admitting the patient, right? Now try to solve this question. What is your answer now? This patient is having consolidation, mycoplasma pneumonia. Is it going to be mycoplasma pneumonia? One pneumonia is left, right? डन. राइट, माइकोप्लाज्मा में क्या होगा? माइकोप्लाज्मा इज गोइंग टू बी एटिपिकल टाइप ऑफ निमोनिया. एटिपिकल होगा, एटिपिकल वॉकिंग निमोनिया, दैट इज द मोस्ट कॉमन कॉज. सो सर दिस कैन नॉट बी द पिक्चर वी आर हैविंग इन द mycoplasma, right? Pneumocystis cerevisiae, you will be having a different picture. HIV positive patient with less than 200 CD4 count. Legionella, I have told you, AC वाला क्वेश्चन आएगा, या फिर contaminated water will be there, that is going to be in the favor of Legionella. BCA will be the buffer charcoal, yeast extract will be the culture media, right? So here in this particular case the answer will be pneumococcus, which is in fact the most common cause of pneumonia, or most common cause for meningitis as well, even in the alcoholic patients also. Alcoholic patient with red currant jelly sputum, bulging fissure sign, then you will be thinking about the Klebsiella. I hope you got it right. Next, a 62-year-old male patient had a surgery. What is the surgery this patient had? That is known as total knee replacement surgery, TKR. Now the patient is having the symptoms of acute dyspnea. Patient is having chest pain, which is increasing on inspiration. This pain is increasing on inspiration. On examination, this patient is having tachycardia. And the BP is low. On ECG, we are finding a sign. This is known as McGinn-White sign. Tomorrow, I think I will be showing, next class, I will be showing you the sign, right? McGinn-White sign is noted. What is the investigation of choice to identify the disease? CT angiography. Everyone. Shubham. It's not the right answer. First, try to make the diagnosis. What is the diagnosis? And what is this McGinn-White sign? This McGinn-White sign is what? Let me make you understand. This McGinn-White sign is going to be your S1, Q3, T3 sign, right? So you will be having large S waves in the first lead one. You will be having this Q waves on the lead number 3, and you will be having this inverted T waves in the lead number 3. Right? So you will be having S1, Q3, T3 sign, and this particular sign is known as what? This is known as McGinn-White sign. And what this particular thing is suggestive of, they are basically this sign is suggestive of straining on right atrium, straining on right side of the heart, right heart. Yes, you're right. Okay, next thing, we are going to assess what is the thing that we are going to have over here, right? The diagnosis. How we are going to make the diagnosis? The diagnosis is what? The diagnosis is pulmonary thromboembolism. So this is a case of pulmonary thromboembolism. This is a patient who is lying down for such a period of time after a surgery, right? After a total knee replacement surgery, this patient is having episodes of acute dyspnea, chest pain, inspiration, tachycardia, hypotension is there, McGinn-White sign is noted, right? What is the investigation of choice to identify this disease? That is what they are asking, right? So look here. This is a case of pulmonary thromboembolism, right? This thing is happening in the bedridden patient. This thing is happening in the bedridden patients. What kind of a image you will be getting? Either the patient is a bedridden patient, either the patient is a old age patients जो चल फिर नहीं पा रहा है, right? Or the patient had a surgery. That means it is a post-operative patient. Okay, apart from that, now this patient will be having acute episodes of dyspnea. There will be acute episodes of dyspnea, difficulty in breathing, and they will be giving you, there will be pain in the chest. Okay, so acute dyspnea with chest pain, with chest pain, that is going to be the that is going to be the pulmonary thromboembolism, that is going to be the thromboembolism, right? On chest x-ray, what are the different signs you will be finding? Multiple signs you will be finding on the chest x-ray. What are they? You can find Hampton's hump, Hampton's hump. You can find Palla sign, Westermark sign, Westermark sign, Hampton's hump, Pala sign, and Westermark sign. So what is this Hampton's hump? This is going to be a wedge-shaped opacity. This is going to be a wedge-shaped opacity on the side of the lungs. Palla sign will be there. This is going to be a dilated right pulmonary artery. Dilated right pulmonary artery. And this Westermark sign is because of oligemia. Oligemia. Just go through the images once and you will be able to understand what I want to talk about, right? How you are going to identify on ECG, you will be finding a special sign that is going to be SQ, S1, Q3. That is going to be your S1, Q3, T3 sign. That is going to be your S1, Q3, T3 sign, right? For screening, we are going to do D-dimer test. For screening, we are going to do D-dimer test. And the investigation of choice is going to be your CT pulmonary angiography. CTPA, that is going to be CT pulmonary angiography. Okay. If it is a small pulmonary thromboembolism, you can use simple drugs like low molecular weight heparin. You can use enoxaparin. If it is a massive thromboembolism, then you need to go for thrombolysis, right? So if it is a small pulmonary thromboembolism, you can use low molecular weight heparin, drugs like enoxaparin. We are having enoxaparin, right? Or if it is massive one, massive PTE, then you need to go for thrombectomy, that is via alteplase. Alteplase, or along with that you can use LMWH, low molecular weight heparin. Okay, all right. So this is going to be the pulmonary thromboembolism, right? A 26-year-old female patient is presented to OPD with the complaints of cough since 2 days, cough since 2 weeks. Shortness of breath is there, dyspnea. Chest tightness is there. Chest tightness is a very specific feature you will be finding in disease, right? From last 3 days, chest tightness, right? And on examination, what do you find? Wheezing sound. What do you find? Wheezing sound. Due to narrowing of airways, you will be having that wheezing sound. Okay, and X-ray shows you hyperinflated lungs. Hyperinflated lungs are there. On sputum examination, seriola bodies are there, and all of the following can be used in the treatment of this situation. Okay, next question, diagnosis asthma. Wonderful. Okay, so diagnosis is asthma, but what is your answer? Diagnosis is asthma. Diagnosis is asthma, right? Here you will be having, can you appreciate, these are hyperinflated lungs. These are your hyperinflated lungs, right? There will be hyperinflation, right? There will be excess of oxygen will be there, right? You will be having this lungs and you will be having chest tightness. Why this thing is happening? Why this thing is happening? And on sputum microscopy, special signs you will be finding on sputum microscopy, that is going to be your seriola bodies. You can also find Charcot Leyden crystals, Charcot Leyden crystals, or Schwarzman spirals, Schwarzman spirals, Okay, cereola bodies, charcot laden crystals, and Churchman spirals. These are the things you will be finding in the cases of sputum examination of asthma, right? Asthma, right? All of the following can be used for the treatment of this situation, except which one we are not going to use. They want to know which one we are not going to use, right? So for this particular thing, let's try to understand what is asthma. So whenever an allergen is going to come, suppose this is your allergen, it is going to bind with your, suppose this is your mast cell, it will be having what, it will be having addition of what, these are your immunoglobulins, these are going to be your IgE type of antibody, right? So you will be having a complex of mast cells and IgE antibodies. Whenever this allergen is going to come, it is going to bind here, it is going to bind here, and now this mast cell are going to release what, mast cells क्या निकलता है, you will be having release of histamines will be coming out, and this is a phospholipid layer, so you will be having prostaglandins and leukotrienes as well. So they are going to be responsible for the release of histamine, prostaglandin, leukotrienes will be there, right? And these leukotrienes, we already know, this is your exam question, it is the most potent bronchoconstrictor. If they ask you what is the most potent bronchoconstrictor, your answer will be beta bronchoconstriction, leukotriene. Most potent bronchoconstrictor is going to be your leukotrienes, right? So this is going to happen. Now apart from this, this mast cell is going to stimulate, and this allergen is also going to stimulate the antigen presenting cells, or this antigen presenting cells is going to activate your T helper 2 cells. Now this T helper 2 cells are going to activate your interleukin 4, interleukin 5, and interleukin 6. Oh sorry, no, not 6, it is going to activate your interleukin 9, right? Now these interleukins will be making some kind of things. They are going to increase your IgE, and these IgE are going to increase your mast cells, and mast cell is going to increase your histamine. So it is a vicious cycle, you will be having more histamine. Interleukin 5 is going to go to your bone marrow, it is going to be responsible for the bone marrow aggravation, right? It will be making some cells, these are the cells which are going to come out, these are going to be eosinophils, so you will be having eosinophilia, right? Interleukin 9 is going to increase your mast cells again. So ultimately, you know what is happening, allergen is coming and you will be having increase in the IgE, increase in the mast cells, increase histamine, increase eosinophil, and the disease is aggravating. So to stop that, what are the things we are going to have? These are the drugs we are going to have, right? So in this particular case, okay, so what are the drugs we are going to have? Let's try to understand. The first drug, everyone agrees, the D we are not going to give, right? So dupilumab is a drug which is going to inhibit what? Dupilumab is a drug which is going to inhibit your interleukin 4 inhibitor. So it is going to inhibit your this particular cycle, right? So this is going to be your interleukin 4 inhibitor. This is your dupilumab. Another drug we are having, that is going to be your omalizumab. These are the two monoclonal antibodies we are having. One is your dupilumab, another one is your omalizumab, right? Second thing, what is happening in the cases of asthma, whenever the allergen is coming, it is going to come in contact with the mast cells, and now mast cells are releasing histamine. So you already know the function of histamine. The function of histamine is what? It is going to cause bronchoconstriction and vasodilatation. And I've told you, whenever a vessel is dilated, you will be having coming out of something. That is what is coming out means, RBCs are coming out, leading to what? Flushing. Leading to what? Flushing. So whenever you are having any allergic response, whenever you are having histamines, you will be having redness, right? So this thing is going to happen because of this particular histamine, right? So what you need to do, what things you can do, you can take antihistaminic drugs. What are these antihistaminic drugs? These are going to be your cetirizine, levocetirizine group of drugs, right? Apart from that, this particular thing is happening because of leukotrienes. So we can use leukotrienes inhibitor, or let me just draw it for you. So what is going to happen, whenever, suppose this is a cell, I've taught you what is a cell. Cell is the basic structural and functional unit of life, right? So whenever a cell will be ruptured, cell की membrane किसकी बनी होती है? Cell membrane किसकी बनी होती है? That is going to be made up of phospholipid. So whenever anything is going to damage this cell, bacteria, virus, कुछ भी हो, right? What is going to happen? You are going to have release of phospholipid, and now an enzyme is going to work, that is going to be your phospholipase A2, and it is going to make what? It is going to make arachidonic acid. And now this arachidonic acid is going to be acted upon by two things. One is going to be your cyclooxygenase, another one is going to be your lipoxygenase, right? So whenever this cyclooxygenase is going to work, it is going to release what? Prostaglandins and thromboxane A2. Prostaglandins and thromboxane A2. Whereas wherever this LOX is going to work, it is going to make what? Leukotrienes. And we already know leukotrienes are the most powerful bronchoconstrictor, right? Most powerful bronchoconstrictor. So what we need to do, either I can block this particular leukotrienes, right? Leukotriene receptor blocker. These are going to be the drugs. These are going to be your montelukast or zafirlukast. Those people who are taking these drugs in normal common cold, you should not take it because it is a drug for asthma. In normal common cold, you should not take montelukast, right? It is having some syndromes, side effects. Okay. Chiari-Higashi syndrome is one of the side effect of this montelukast, right? You should avoid it, right? Apart from that, we are having this particular thing that is going to be LOX inhibitor, that is going to be your xylutone. Xylutone is going to be your LOX inhibitor, right? I can block this particular enzyme, phospholipase A2. These are going to be the drugs. These are your steroids. These are going to be your steroids. These are going to be your steroids, right? Apart from that, what is the problem we are having? The problem we are having is bronchoconstriction. So what we can do bronchodilation, and bronchodilation is with the beta 2 agonist. Beta 2 agonist drugs like salbutamol, salbutamol, okay, salmeterol, metro वाले जो है, these are going to be long acting salmeterol, right? Apart from that, salbutamol, salmeterol, we can add these drugs along with the steroids. That is going to be the best combination, right? So these are the things. Now in our option, we are having one drug which is a COX inhibitor, that is going to be aspirin. And you must have heard about a term that is aspirin induced asthma, right? Aspirin induced asthma. So how this aspirin can induce asthma? Look here, it is going to block this COX. Now what is going to happen? All the arachidonic acid will be metabolized here. You will be having more levels of leukotrienes, and this is how this aspirin can induce asthma. So in this particular case, the aspirin is the drug we cannot use, and this is going to be the answer. What about this aminophylline and this methylxanthine? In fact, this methylxanthine is going to incorporate two things. One is your aminophylline, another one is your theophylline, right? So this methylxanthine will be having theophylline and aminophylline, right? They are going to inhibit your phosphodiesterase enzyme. They are going to inhibit phosphodiesterase enzyme, and if phosphodiesterase is inhibited, what is going to happen? You will be having increased levels of cyclic AMP, and remember, this cyclic AMP is going to responsible for the bronchodilation and decreasing the inflammatory mediators. So this is how these two drugs are also working. But if you do not have these drugs, you can take coffee also, black coffee. In emergency, you can take black coffee. It is also a bronchodilator, right? So this is the thing, right? One more drug we can I can teach you, that is going to be your nidocromil or sodium chromoglycate. It is a mast cell stabilizer. It is a mast cell stabilizer. So it is going to prevent the rupture of these cells, but it is given prophylactically. It should be given before the emergence of the symptoms, right? So these are the basic problems we are having, but the most important thing, to avoid the allergen, is the best thing that we can do. Prevention is better than cure, right? So this is the thing we need to remember, right? Last question we are having: a 62-year-old male patient suddenly collapsed in park during jogging, right? एक पेशेंट है, वो पार्क में अचानक से गिर गया. फॉर्चुनेटली अ डॉक्टर वॉज अवेलेबल, सो समवन फ्रॉम यू वॉज अवेलेबल ओवर देयर, and he checked for the carotid pulse. You check for the carotid pulse of that particular person and breathing of the patient, and both are absent. So this particular patient do not have a pulse. This particular patient do not have a respiratory rate also, right? This patient is not breathing at all. So what you need to do, what you suspect, if there is no pulse and no breathing, you suspect this is a case of cardiac arrest. This is a case of cardiac arrest. Now nothing is working. ना तो दिल काम कर रहा है, ना respiration काम कर रहा है, okay, circulation is also stopped. So in this particular case, in cardiac arrest, we need to give what? Cardiopulmonary resuscitation. Cardiopulmonary क्यों बोला? दिल बंद है और pulmonary lungs बंद है, right? So we need to restart it, that is CPR. After some times the ambulance has arrived and he wanted to start on ACLS. Now advanced cardiac life support is going to give. Which of the following is the drug administered is going to save the life of the patient? So what is the drug would you like to give? What is the drug would you like to give in this particular case? Is it going to be your epinephrine, norepinephrine, atropine, digoxin, or something else you would like to add? Yes. One is to 1000. No, Shubham, 1 is to 10,000 IV. 1 is to 1000 means what? It means what? So you are having a vial of injection. Let me make you understand. You are having a vial of bolus, right? And in that particular thing, if I am taking 1 ml out, that is the concentration 1 is to 1000. Now, if I am diluting 9 ml of saline into that, if I am diluting 9 ml of saline, now it is going to become what? Now it is going to become 1 is to 10,000. And this is the dose we are giving. 1 is to 10,000 we are giving. मतलब 1 ml तो adrenaline लिया and 9 ml I'm taking the normal saline, and then if I'm injecting, that is going to be the 1 is to 10,000 concentration. If I am using 1 ml and directly injecting, that is going to be 1 is to 1000 concentration. That needs to be given in the cases of anaphylaxis. The question they are asking, you are traveling on a plane and someone has started to develop some anaphylactic reactions, right? This patient is going to have bronchoconstriction, he is not able to breathe, everything is happening. Then you are going to give this 1 is to 10 or 1 is to 1000 IM, right? You just need to take the adrenaline from the tray, right? They are having emergency box, and you just need to take 1 ml, just inject it, and the patient will be fine, right? That is what you need to do in the cases of anaphylaxis. But for the cardiac arrest will be a different approach, right? You can directly, either you can go directly, you can do intraosseous, you can give intraoral, not oral, intratracheal if the patient is already intubated, right? You can give IV line, whatever route you can administer, you will try to just save the patient, right? So that is going to be the thing. But what is the drug would you like to give, right? So that is going to be the remember why we are not giving epinephrine, norepinephrine. It is going to work not all. You can remember, not adrenaline, not epinephrine, not all, right? So it is not going to work on all receptor of sympathetic nervous system. We are having three receptor. It will be working, right? It will be working on alpha 1, which is going to responsible for vasoconstriction. It is going to work on alpha 2, which is going to be a moderately acting thing, right? And it is going to work on beta 1. Beta 1 is present at 3 places. SA node, it is going to increase your heart rate. AV node, it is going to increase your conduction beta, right? And in the muscle, it is going to be responsible for the muscle contraction, right? Apart from that, it is going to be present in your kidney, which is going to release renin, and renin is ultimately responsible for increase in the BP of the patient, right? And this thing is going to be the thing with the norepinephrine. But epinephrine is going to work on alpha 1, alpha 2, beta 1, and beta 2. Beta 2 is responsible for bronchodilation, right? In this particular cardiac arrest patient, cardiac arrest के patient में क्या हुआ है? Cardiac arrest के patient में सांस भी तो नहीं आ रही, heart is lungs are also stopped, right? So the drug of choice in this particular case is going to be your epinephrine. You must have seen in the movies, कोई आता है एक इंजेक्शन यहाँ लगाता है, CPR दे रहे हैं, they just try to revive it, right? So that is going to be the this component, which is why we are having the drug of choice as epinephrine. Never use norepinephrine. Norepinephrine is drug of choice in the cases of shock. In this cases of shock, it is increasing vasoconstriction, BP बढ़ा रहा है, BP बढ़ा रहा है. That means it is going to be responsible for increasing the activities in the cases of shock, right? Atropine is going to be the drug of choice in the bradycardia whenever there is decreased heart rate. Atropine का function लिख लो तुम तो. It is going to increase your heart rate, it is going to increase your conduction. That means it is going to work at 2 places, SA node and AV node. It is going to increase your heart rate, it is going to increase your conduction. So we are going to use it in the cases of heart block, In heart block, what is happening? The conduction is not happening properly, right? ऊपर से नीचे impulse नहीं आ रही, that is heart block. Atria से ventricle में impulse नहीं आ रही, there is some problem with the this particular AV node. This is known as heart block, right? In organophosphate poisoning also, the drug of choice is going to be atropine. What about this digoxin? It is going to used in the cases of heart failure. Listen to me, all these terms are different. Heart failure में क्या हो गया? Failure is not permanent, failure is temporary, right? So what is going to happen? Heart failure मतलब heart ढंग से pump नहीं कर पा रहा है, right? So it is going to increase the contractility of heart. It is going to work on which part? मसल. इट इज़ गोइंग टू वर्क ऑन द मसल ऑफ द हार्ट. देखो हार्ट में तीन चीज़ें होती है, एस नोड, एवी नोड और मसल. मसल के ऊपर क्या काम कर रहा है? डिजॉक्सिन काम कर रहा है. अट्रोपिन कहाँ काम कर रहा है? एस नोड और एवी नोड. दैट मीन्स इट इज़ गोइंग टू बी रिस्पॉन्सिबल फॉर इंक्रीज इन हार्ट रेट, इंक्रीज इन कंडक्शन, राइट? यू अंडरस्टैंड? सो दिस इज गोइंग टू बी द epinephrine. What is the algorithm? What is the BLS algorithm? देखो ये important है. I have not covered it in anesthesia also, so you can look it here, right? So this is going to be the first thing. Whenever you are finding a patient with the suddenly collapsed, what you need to do, you need to first check for the scene safety. I've seen people, they are doing CPR on the main road on a highway, right? That's a wrong thing. You need to check for the scene safety first, and it has been asked in your examination also question. ठीक है. Second thing, you will be checking for the responsiveness. You will tap the person whether he is alive or not, whether he is okay or not. You must have seen the reels right now, right? Nowadays people are giving CPR to patients who are just talking or walking like they are speaking like that. Okay, so you should not do that, right? Check for responsiveness. Second thing, shout for help. You need to shout for help. Activate emergency response. You need to call, not in India we are having 108 or something like that, right? You need to call for that. And you need to get AED. What is this AED? That is going to be your automatic external defibrillator. That is a machine which is going to give the DC shock, right? Now you will be looking for the, after this work you will be looking for the no breathing, looking for the breathing, right? Looking for the breathing and looking for the pulse. Carotid pulse देखना है, breathing देखना है, ठीक है? नॉर्मल ब्रीदिंग और पल्स आ रही है तो क्या करना है? जब तक कोई आ नहीं जाता, ओके, जब तक कोई नहीं आ जाता तब तक वेट करना है, कुछ नहीं करना, उसको ज़बरदस्ती CPR नहीं देना है. इफ़ द पेशेंट इज़ ब्रीदिंग फाइन, इफ़ द पेशेंट इज़ हैविंग पल्स, यू शुड नॉट गिव एनीथिंग, राइट? सेकेंड थिंग, नो नॉर्मल ब्रीदिंग लेकिन पल्स आ रही है, ब्रीदिंग नहीं है लेकिन पल्स आ रही है, देन व्हाट यू नीड टू डू? यू नीड टू गिव ब्रीदिंग ओनली. अभी CPR नहीं देना, ओके? सो प्रोवाइड रेस्क्यू ब्रीदिंग. 1 ब्रीथ एवरी 6 सेकेंड. मतलब 1 मिनट में कितनी ब्रेथ देनी है? That is going to be 10 breath. यानी every 6 second we need to give 1 breath to him, right? Then we need to check for the pulse every 2 minutes. हर 2 मिनट में पल्स के बारे में चेक करना है, if pulse is present or not, right? अगर पल्स एबसेंट है तब क्या करना है, right? थर्ड थिंग, this is also important. अगर if you are thinking, if you are finding that patient is having signs of mainlining or something, like ऐसा लग रहा है कि opioid poisoning का patient है, then you need to administer naloxone as soon as possible अगर opioid overdose का patient लग रहा है, right? Apart from that, ओपियोइड ओवरडोज के पेशेंट में देखो, ओपियोइड का एक साइड इफेक्ट होता है, दैट इज गोइंग टू बी रेस्पिरेटरी डिप्रेशन. This patient is having pulse, but this patient is having respiratory depression, which is going to lead to absence of breathing. You understand, right? अगर breathing नहीं है और pulse भी नहीं है, दोनों ही चीज़ें नहीं है, then it's your time to act. Now you need to start CPR. Previous year question, how many compression you will be giving? Performing cycles of 30 compressions followed by 2 breath. Okay, 30 compression, 2 breath, right? Then you will be getting the external डिफिब्रिलेटर, ऑटोमेटिक एक्सटर्नल डिफिब्रिलेटर, उसको अटैच कर देना है, यहाँ लगाना है, साइड में लगाना है. इट इज़ हैविंग द इंस्ट्रक्शंस ऑल्सो, राइट? देन उसमें बटन दबाना है, एंड देन यू विल बी फाइंडिंग द रिदम इज शॉकेबल और नॉन शॉकेबल. बटन दबाने के बाद में पता चल जाएगा उसमें कि रिदम शॉकेबल है कि नहीं है. अगर रिदम शॉकेबल है देन यू विल बी प्रेसिंग द बटन, उसको बटन दबाना है एंड इट विल बी गिविंग द शॉक टू द पेशेंट. ओके, what will happen? Give one shock and again then resume the CPR, okay, immediately for 2 minutes. 2 मिनट तक CPR देना है, okay, और 2 मिनट के बाद में उसको वापस से चेक करने के लिए देना है. मतलब जो मशीन है, इट विल बी चेकिंग अगेन, ओके, इट विल बी चेकिंग अगेन द रिदम. अगर ठीक हो गई, पल्स आ गई तब तो ठीक है, अगर पल्स नहीं आई तो अगेन वी विल बी गिविंग द शॉक, राइट? एंड कंटिन्यू ALS. कंटिन्यू अंटिल ALS प्रोवाइड द सपोर्ट, मतलब जब तक एडवांस कार्डियक लाइफ सपोर्ट नहीं आता तब तक उसको कंटिन्यू रखना है. दैट इज वॉट यू नीड टू डू, राइट. अगर नॉन शॉकेबल रिदम है, अगर रिदम नॉन शॉकेबल है, द रिदम इज नॉन शॉकेबल, यू जस्ट नीड टू रिज्यूम योर CPR इमीडिएटली. अगर मशीन लगाई तुमने एंड यू आर फाइंडिंग इट इज़ अ नॉन शॉकेबल रिदम, तो तुमको शॉक नहीं देना है उसको, उस पेशेंट को. यू नीड टू resume your CPR again. You need to continue your CPR. After sometimes, after 2-3 minutes, you need to again check whether the rhythm is again shockable or non-shockable. अभी भी non-shockable जब तक है, you need not to give any shock to the patient. You just need to continue your CPR कंटिन्यू करना है. देन एडवांस कार्डियक लाइफ सपोर्ट वाले आएंगे. दे विल बी डूइंग व्हाट, दे विल बी गिविंग दिस पर्टिकुलर पेशेंट द इंजेक्शन ऑफ एपिनेफ्रिन. इसको एपिनेफ्रिन लगा देंगे. एपिनेफ्रिन से भी अगर काम नहीं हो रहा है, एपिनेफ्रिन का फंक्शन क्या है, अभी बताया था, ऐसे नोड, AV नोड, मसल, तीनों को एक्टिवेट करेगा, BP बढ़ा देगा, पेशेंट को वापस जिंदा करेगा, ब्रोंकोडाइलेशन कर देगा. दिस इज गोइंग टू बी द फंक्शन ऑफ एपिनेफ्रिन. अगर इससे भी काम नहीं चल रहा तो वी कैन ऑल्सो यूज अट्रोपिन, because atropine is also going to be responsible for increase in heart rate and increase in conduction, right? So we can also give atropine along with that. Depending on the situation, we can utilize these things, right? Okay, so these things we need to do. So this is how we are going to save our patient of cardiac arrest. Cardiac arrest मतलब अचानक से दिल बंद हो गया और lungs भी बंद हो गए. Heart failure मतलब heart is not able to pump the blood effectively. And lastly thing, heart block मतलब we are having problem with the conduction of impulse, यानी above chamber से नीचे impulse आने में कोई ना कोई issue हो रहा है. That is going to be your heart failure, right? With this thing we are done with the first part of the medicine. Okay, so we are done with this. Stop doubting yourself, work hard and make it happen, right? This is what is important. And I really hope amiodarone we will be using in the case if we are having arrhythmias. If we are having arrhythmias, I will be teaching you tomorrow. In next class, I will be discussing about the CVS part. Okay, I will be sending the PDFs over here. You can download the PDF from there, and don't doubt yourself. You guys are doing amazing, and thank you so much for all the patience. And we will be meeting in the next class where I will be discussing about the parts of CVS and the remaining parts of the medicine. And then we are having one more session for the examination. Please do join that. Okay, I would be explaining you how to give the exam on 10th. It will be there, right? So don't worry about. Thank you guys.